since it's a case discussion, we can keep it little loose to the end, depending on the merit of the case. I'm sure one or two cases will warrant more time because they may have a better message to give. So I think
it is up to you.
Yes, definitely.
Okay, all right.
Yeah.
Okay, it's 10:30. Sandeep?
Yes.
We are live, sir.
Yeah, Dr. Shinde has also joined in. So on behalf of the Maharashtra Orthopedic Association and the Bombay Orthopedic Society, I welcome you to yet another edition of Momentum 2021. Momentum 2021 is the joint effort of the MOA and the BOS to promote IOACON 2021, which will be held in the last quarter of the year 2021 in the city of Mumbai. Today we have as the guest chapter the Indian Society for Surgery of Hand. This society is indeed a very old society, which was solemnized on the 15th of August 1973. It was built by the efforts of a lot of stalwarts of hand surgery of that era, including the great Dr. B.B. Joshi. And over the years, a lot of senior members have led this society, including orthopedic and plastic surgeons, to presently where this society is, which is at the summit of academic excellence. May I now hand over the proceedings of the meeting by inviting Dr. Ajit Shinde, the President of Maharashtra Orthopedic Association and also the Organizing Chairman of IOACON 2021. His welcome address would be followed by that of the BOS President, Professor S S Mohanty, who is the co-organizing chairman of IOACON 2021, followed by Dr. Parag Sancheti and Dr. Chaddha, who are the conference directors and the organizing secretary of IOACON 2021. Once we are done with our dignitaries, we would invite the president of the ISSH, Dr. Ravi Mahajan, to give his address, following which we will hand over the proceedings to Dr. Pankaj Ahire and Dr. Pankaj Jindal for the meeting to start. Over to Dr. Ajit Shinde. Welcome, sir.
Thank you, Swapnil. Good morning, everyone. I am Dr. Ajit Shinde, Chairman of IOACON 2021 Organizing Committee and President of Maharashtra Orthopedic Association. Welcome you all again in this MOA BOS webinar series called The Momentum. Talking about this initiative, it has been a great learning experience for all of us. Today again, we are back with interesting topic of industrial hand injuries under the subject heading of wrist and hand injuries. And we have brilliant panel of experts to discuss these critical problems. I would like to welcome and thank the Indian Society of Surgeons of Hand for their enthusiastic participation, especially President Dr. Ravi Kumar Mahajan and Secretary Pankaj Ahire. I would like to mention an interesting fact that we have got one credit point for the academic activity from Maharashtra Medical Council, and we have Dr. Uddhav A Patil as a MMC Observer here today, who is my senior in VMMC by 2 years. Welcome, sir. I would like to announce that MOA accreditation with MMC has been evoked and our academic activity have been well acknowledged by MMC in terms of credit points. So industrial injuries can be disastrous for an individual as the most phenomenal feature of human being that the hand is compromised in most of the situation. So it is very, very important to provide utmost care and treatment even in rehabilitation phase to give maximum function. Many times, Workman Compensation Act has played a variety of roles in such cases, and one must be aware of this fact if you are dealing with such cases. We have with us Dr. J. Karthikeyan, a renowned senior plastic surgeon from Chennai. We all know Pankaj Jindal, an expert in this field. Dr. Venkataramani, another well-known plastic surgeon from Ganga Hospital. Also along with them we have Dr. Joshit Balan, Dr. Rajendra Nettate, Dr. Ravi Mahajan, and our own Dr. Pankaj Ahire, all the very expert in this field, presenting various cases scenario of industrial hand injuries along with above mentioned stalwarts. Lastly, I would like to applaud with my heart for the extraordinary effort from the young and dynamic team consisting of Dr. Swapnil Keny, Dr. Pradeep Nemade, Dr. Sandeep Biraris, and Dheeraj Sarone. All of them worked hard to make each episode full of interesting and academic discussion. I hand over now this mic to our Vice President, Dr. Mohanty, for further proceeding. Thank you. Thank you very much. Jai Hind, Jai Maharashtra.
Thank you, Dr. Shinde, sir. Dear friends, good morning to you all and greetings from Mumbai. Welcome you to this webinar, which is a joint venture between MOA and BOS. And we have rightly termed it as momentum, and the momentum towards the IOACON. As IOACON 2020 is moving towards IOACON 2021 because of the pandemic, the momentum had been slow, but academic knowledge and the quest for the knowledge of academics has not been slowed down by the organizing committee of IOACON. That's why this effort. Let's gain this momentum towards IOACON 2021. As we are opening up gradually, I can see now the glow in everybody's face and the positivity which we are gaining. And towards this positivity, let us march ahead. And I wish this webinar a great success. And I thank Indian Society for Surgery of the Hand, Dr. Ravi Mahajan and team, and the two stalwart Pankajas, which are there to moderate this webinar. And hopefully that we will gain a lot of knowledge today towards the hand surgery. I thank you again and hand over these proceedings to Dr. Parag Sancheti, the conference director for IOACON 2021.
Thank you very much, Dr. Mohanty. Very good morning to all of you. Respected President, Dr. Shinde sir, President of Bombay Orthopedic Society, Dr. Mohanty, our organizing secretary, Dr. Chaddha, President of the ISSH, Dr. Mahajan, Secretary, Dr. Ahire, and the moderators for today's program, Dr. Jindal, Dr. Ahire. It's really a great pleasure to welcome all of you for this excellent webinar. I think it's very important. And first of all, thank all the office bearers of the Indian Society of Surgery of Hand and its executive committee and members for participating and joining hands with Momentum. As told to you earlier, this activity has been created actually to gain momentum as we proceed towards the last quarter of 2021, where we are going to have the IOA conference and it was supposed to be held, and right now we would have been really busy preparing for it had it been in December as planned earlier. But due to the pandemic, we could not, and now it has been postponed. So this is an activity towards that, and I request all the members of ISSH to support this meeting, start registration, send in your papers, because I think it's very important to now start getting the momentum. A lot of work has begun, and as we proceed, Dr. Ram will tell us more about the activities. But I really want to say that, as we were just discussing before starting this webinar, there seems to be a little bit of rejuvenation. There is a little bit of celebration, if I may use the word jubilancy, because things are opening up, things are getting better, the numbers are going down, and slowly, we are getting to normalcy. One thing different between a man and his ancestors is man always likes to socialize. So even though these webinars have kind of filled up the space, I don't think they can go on forever. As a social requirement, as a human requirement, we have to meet face to face, and I'm really looking forward to the first physical meeting, and hopefully it will be YROC or sometimes something even before, and have a glass of wine with all of you. That's really the important thing what we require. Academics will go on, but along with academics, I think that is also more important. I want to thank today's faculty who have participated, Dr. Karthikeyan, Dr. Hari, Dr. Balan, my friend from BJ Medical, Dr. Rajendra Nehte, who's, we have been very close friends. So thank you, Neha, Dr. Swaminathan, Dr. Valar, all the people who are joining today. Really, it's a fantastic faculty. Don't want to take much time, but, of course, Swapnil and Sandeep and Memade have been doing an incredible job of putting this together. So congratulations to them. And I wish this webinar of ISSH along with BOS, MOA, Momentum, a great success. And I look forward to learning more about hand surgery. And I'm sure Dr. Jindal, who has got a great experience in hand, will do a great job and definitely add value to all his viewers. So I wish this success, and also to Dr. Ahire, who will be conducting with him. Thank you very much.
Thank you very much, Parag, for your words of wisdom and optimism, inspiration on the way forward. Thank you, Dr. Ajit Shinde, Dr. Mohanty, Parag Sancheti, my dear friends, Dr. Mahajan, both the Pankaj Ahire as secretary, Pankaj Jindal as moderator, senior, and Pankaj again, and the entire gamut of lovely hand surgeons. It is said that people who work with their hands are laborers. Those who use their hands and their heads are craftsmen. Those who use their hands, heads, and hearts are artists. So the common denominator is the hand. So please remember that whatever the mind conceives, the heart believes, the hands achieve. So let us all gather momentum, move ahead, hand in hand, holding each other towards the last quarter of 2021, where each one of you have to be a handyman and hand over whatever you have as the best, so that we can have a lovely conference of IOACON 2021. Wishing the ISSH, all the office bearers, and this plethora of brilliant hand surgeons all the best for the next couple of hours, where academics will be discussed hand in hand, threadbare. All the best. God bless you.
Thank you very much, sir.
Well spoken, Ram. Well spoken.
Yeah. It is my greatest privilege to now invite the president of the ISSH, Dr. Ravi Mahajan, to say a few words before we begin this meeting.
Good morning, everyone. So on behalf of Indian Society of Surgery of Hand, I must welcome all the participants to this great initiative taken by the Bombay Orthopedic Association and the Maharashtra Orthopedic Association, creating a momentum for the IOACON. So I think this is really a great initiative, and I must thank all the office bearers of the Maharashtra Orthopedic Association, Bombay Orthopedic Association, and the organizing committee of the IOACON, who have invited the Indian Society of Surgery of Hand for this very useful webinar. And as Dr. Chaddha has pointed out, that hand is very, very important. And the best thing is that the combination of orthopedic surgeons and the plastic surgeons, they join together to deal all the problems of the hand. And I think that is where the ISSH has got a great role to play, that it's coordinating between the orthopedic surgeons and the hand surgeons, rather than they competing with each other. In fact, they are enriching each other. And that is what the Indian Society of Surgery of Hand has been playing the role over the last so many years. And as Dr. Shinde was pointing out, that the many stalwart orthopedic surgeons and the plastic surgeons have been involved, in the momentum which was created for the Indian Society of Surgery of Hand, and we do stand on the shoulders of those stalwarts. And with these words, I would wish a great success for this webinar, as well as the coming webinars for the creating momentum for the IOACON. And I'll be very happy, if the Indian Orthopedic association involves the plastic surgeons as far as the compound lower extremity injuries are also concerned. Because what I have seen over the years is that the combined wisdom and the work of both orthopedic surgeons and the plastic surgeons can really, do very well for our patients. So with these words, I would, again welcome you all and hope that this webinar will be very useful to all the attendees. And again, I thank you very much, all the office bearers of the orthopedic associations. Thank you so much.
Thank you very much, sir. I now hand over the proceedings to Dr. Pankaj Jindal and Dr. Pankaj Ahire. Over to you, sir.
Ahire, please.
Pankaj, you need to unmute. Yeah.
Dr. Ahire.
Thank you, Swapnil. I welcome all of you. I welcome my co-moderator, Dr. Pankaj Jindal. We straight away start with the academic session, and it's my pleasure to invite Dr. G. Karthikeyan. Dr. G. Karthikeyan is a professor and head Department of Hand and Plastic Surgery at Stanley Medical College. Stanley Medical College is the place where the first dedicated hand surgery department of this country was started by Professor R. Venkataramani, and GK and now heads that department. So it would be wonderful to get his insights on machine injuries pertaining to the fingers, the most commonly injured part of the upper extremity. Over to you, Dr. Karthikeyan.
Hello, thank you, Pankaj. Good morning to everyone and all our brother members of the Association of IOACON. In this regard, I would like to also say that we, the Indian Society for Surgery of the Hand, are conducting the 2021 conference also in the last quarter of 2021. And we look forward to a lot of interrelationship and programs between us. Thank you very much for inviting me to talk at this webinar. I'll go into the presentation. Can I share my screen now?
Yes, please.
Please, sir.
Yeah, I'll be talking on soft tissue cover for multiple finger injuries, the non-microsurgical options. Now, we get a lot of multiple finger injuries, and the management of this is quite simple actually once we get to understand the dynamics of the finger and the problems and the principles involved in the management. We'll go into this management. So under this, in the next 15 minutes or so, I have planned to talk for about 12 to 13 minutes, after which we'll have a discussion of two cases. So the causes of such defects will be seen. This I know is about industrial hand accidents, but we will also be seeing other accidents where you have multiple finger defects. Then when having come across a patient with multiple finger defects, what are the factors to be considered during the reconstruction of such defects? And what are the options that are available to us? What are the different types of reconstruction that can be done? And if it is possible to make a simple algorithm so that even the junior most person, the resident, will be able to make a plan of his own when he's confronted with such an injury. Now, the causes of such defects, that is, multiple finger defects, can be either trauma, which could be due to road traffic accidents or machinery, and trauma usually involves the dorsum of the fingers and ulnar borders. This is for road traffic accidents. For industrial accidents, you can have it on anywhere of the finger. Electrical burns also, they get a lot of multiple finger defects where it could involve the contact areas and the contiguous fingers. Industrial accidents, here specifically, we will see what is specific, what is so characteristic about the industrial accidents that is different from the other injuries, other etiologies. And lastly, after release of abdominal contractures, finger contractures, when you have a contracture of multiple fingers, when you release them, you get a resultant defect on multiple fingers. So that also has to be resurfaced. So when you consider the causes of multiple defects of fingers in road traffic accidents, you have there is more of contamination and friction burns. What is known as friction burns, as the hand is dragged along the road or the surface that is being where the accident has occurred. In electrical burns, you have multiple finger defects, but there is a lot of deeper involvement, and sometimes the vascular problem is there, vascular compromise is there, leading to gangrene of the distal portion of the fingers. Then we have industrial accidents, which may be sharp, which may be avulsion, which may be crush. It can be any, that is why industrial accidents form a major part of this chunk of this multiple finger defects, because it encompasses any type of injury. And lastly, of course, post-contracture release, which is a little different because it is a surgically created wound on multiple fingers. So what do we need to consider? Once we have a patient with the multiple finger defects, what do we need to consider before considering reconstruction? First is we need to know what are the other parts of the hand that may be involved. For instance, if the patient has got multiple defects on the fingers, he may also have a degloving injury on the forearm. That also needs to be taken into consideration. Next is the number of fingers involved. Here, the involvement of the thumb makes a big change in the planning. So that also should be considered. Then the parts of the fingers that are involved. Is it the volar aspect? Is it the dorsal aspect? Or is it the ulnar aspect or radial aspect? We'll go into all those as we go along with the presentation. And lastly, which is the segment of the finger that is involved? The terminal phalangeal region, middle phalangeal region, or the proximal phalangeal region. Now, all these are important. The last two that I have said, that is the part of the fingers involved and the segments of the fingers involved. Now, these are very important because they are going to tell us what should be the ideal plan for that particular hand that has been involved. Now, when we consider the reconstruction options, we have got mainly three options. First is all the defects, just put a skin graft, either a split thickness graft or a full thickness graft. The second option is all the defects give flap cover. And thirdly, some defects you can flap, some defects you can graft. Now, obviously, all defects, if you want to put a graft, all defects, we know that we cannot put a graft, and the graft will not take up over bare bone, bare tendon, or bare cartilage. The joints are exposed, you cannot put a skin graft. And if the bone is exposed or the tendon is exposed, you cannot put a skin graft. So the options of all defect skin grafting is quite rare except in contracture release. That, of course, we are not going to consider today. And secondly, some defects grafting, some defects flap, also we will not consider. No, we will consider only the patients who will need a flap reconstruction for all the finger defects that are going to be seen. Now, when we consider flap defects for multiple finger defects, flap reconstruction for multiple finger defects, we have got basically two types of reconstruction. The type 1 reconstruction is you convert all the multiple defects into a single defect and cover with a single flap. So once you have done that, when you convert the multiple defects to a single defect, what you're doing is you're creating what is known as a surgical syndactyly. You're putting all the fingers together and suturing them together, so all the defects becomes one defect. That is covered with a single flap. It is quite simple now. So that can be done. The second is, but the problem with that is all the fingers are stuck together and the patient will need another surgery when you need to release all the fingers, that is, release the surgical syndactyly. The type 2 reconstruction is when you give individual flaps for the defects. Now, this is more challenging. The type 2 reconstruction is of three types. You can cover all the defects with what are known as intrinsic flaps. That is, you take flaps from the neighboring areas, from the neighboring fingers, from the neighboring skin, and put it and cover the defects. So this is type 2A. That is, you are giving individual flaps for all the defects using the intrinsic flaps. That is from the hand itself. The type 2B is when you cover all the defects with distant flaps. And we know that distant flaps are those flaps that are at a distant area from the hand. For instance, we can take flap from the skin, from the abdomen or from the groin region. So those are distant flaps. So if you cover all the finger defects with individual abdominal flaps, it comes under type 2B reconstruction. And type 2C, of course, is a via media between the two. Some defects you use intrinsic flaps and some defects you use distal flaps. So now that makes some sort of clarity is obtained now. You can do either a type 1 reconstruction where you convert all the multiple defects into a single defect and cover it with a single flap. The second is when you give individual flaps for the fingers. If you're going to use flaps from the hand region itself, it is called type 2A reconstruction. Type 2B, when you're going to use multiple flaps from a distant region, either from the abdomen or the groin. And type 2C, we're going to mix intrinsic flaps, some intrinsic flaps and some distant flaps. So today we'll be considering these type 1, type 2A and type 2B. Now this is an example of type 1 reconstruction. Now this is actually an electrical burn where this child has got a burn on the fingers, all the fingers extending up to the palm and the thumb. Now it is very difficult to give single individual flaps from the hand because the hand is involved to a major percentage. You have to give flaps. So it is ideal to do what is known as a type 1 reconstruction. So all these are joined together. You can make out the surgical syndactyly being created here. And here from the abdomen, the paraumbilical flap is planned and the paraumbilical flap is done. I told you one of the drawbacks of this reconstruction is that the patient will require another surgery where we need to do a surgical syndactyly release. That also has been done for this patient. So this is the type 1 reconstruction for multiple finger defects. Now, type 2A reconstruction is when you give only intrinsic flaps for individual intrinsic flaps. Now look at this patient who has had an amputation of the tips of the index finger and the mid finger. So here what has been done is bilateral cutler flaps have been used. That is lateral advancement flaps for both the fingers. You can make out one flap from this side, one flap from this side. Similarly, two flaps from the middle finger. And this is the result. So this can be done only in some situation. And when we are forming the algorithm, we'll try to find out when you can do a type 1, when you should do a type 1 reconstruction, when you should do a type 2A reconstruction. Now, this is another example of type 2A where you're giving individual flaps from the hand itself for multiple fingers. Now, this is the pressing machine injury, cutting machine injury of the ring and little fingers, where the part of the one half of the tip of the finger has been amputated on the ring and little fingers. So what we have done is we have done a cross finger flap from the ring finger for the little finger and from the middle finger for the ring finger. And this is the result. And this is the donor site. So cross finger flaps, as we know, are quite versatile, but we need to avoid taking the cross finger flap from the index finger. The second problem with using this type of reconstruction is positioning becomes a problem when you go beyond 2 fingers. And we should remember that even though the donor site is good, it is advisable not to take a cross finger flap from the index finger. And post-division therapy is important because the fingers have been kept at flexed, acutely flexed at the proximal interphalangeal joint for a period of 2 to 3 weeks. And after release, we must mobilize them, otherwise they go in for stiffness. So this is the type 2A, another example of type 2A reconstruction where individual flaps have been given for the defects. Now this is the third type of type 2A reconstruction where the thumb and the index finger are involved. So here we know that when the thumb is involved, it is ideal to give a sensate flap. So we usually take the neurovascular island flap from the middle finger. But when here the index finger is also involved, so we need to take a flap, cross finger flap from the middle finger. So that makes it a little problematic. So what we can do is we can use other intrinsic flaps for this finger. So what we have done is we have taken a neurovascular island flap from the middle finger for the thumb to give it a sensate skin. And for the index finger, we have taken a homodigital island flap, reverse flow homodigital island flap from the index finger itself. And this is the final result. So this way you can resurface multiple defects on the fingers with flaps taken from the hand and other fingers itself. Now we come to type 2B reconstruction, which is taking flaps, individual flaps for the fingers from the distant areas like the groin or abdomen. Now the indications for this sort of reconstruction, now this makes it a little difficult to conceive because you're going to take multiple flaps from the abdomen and we need to make sure that it is held comfortably and it is planned comfortably. So multiple finger defects distal to the proximal region, proximal phalangeal region are ideal for this sort of reconstruction. Remember, multiple finger defects distal to the proximal phalangeal region and defects on fingers combined with hand or hand, volar or dorsal areas. So this, what we can do is we use what is known as stepladder abdominal flaps, otherwise called louver flaps, combined with groin or paraumbilical flaps. And we'll also see the salient points. Now, when we do a type 2B reconstruction, we should remember when there are multiple fingers like this involved, there is a gentle curve. You can make out that curve over here. So this curve should be remembered when you're planning the flaps also. So the flaps have been planned with the same gentle curve on the abdominal wall. The flaps have been raised. It is not necessary to raise these flaps up to the fascia because these are random pattern flaps and they can be raised only up just below the dermis. So we can resurface all the defects and get good results and good function. Now, it can also be used when you have a defect on the terminal phalangeal region of the volar aspect plus degloving injury. When there are degloving injuries, it becomes more ideal because you cannot resurface the degloving injury with an intrinsic flap. So then you necessarily need to go for a distant flap. If these three fingers had defects over here, we could have salvaged that with just type 2A reconstruction. But here what happens, there is a degloving, so we need to combine it. So then you can take multiple flaps from the abdomen and the groin flap to resurface all these defects. Now, we also need to remember that when you have dorsal or ulnar defects, we need to plan inferiorly based abdominal flaps. You can note when you take multiple flaps, there must be a distance of about 1.1 to 1.5 centimeters between the pedicle of the first flap and the edge of the second flap. This must be strictly adhered to because we do not want to compromise the vascularity of the flaps. So if it is dorsal or ulnar defects, we take multiple inferiorly based abdominal flaps to get good results. It is very important that the patient is comfortable, the hand is comfortable in these sort of defects taken from the distant areas. So planning is most important. Now, when you have radial side defects, now look at this hand. He's got a radial side defect on the thumb, on the ring finger, mid finger, and the index finger. So here, what we have done is, when you have radial side defects, it is ideal to take superiorly based abdominal flaps. So here the flap has been taken for the thumb and these for the other fingers following the gentle curve that I was talking about. And the comfortable lie of the hand when it is kept on the abdomen will give you a good result. What do we do when we have contiguous? We have spoken about ulnar side defects. We have talked about radial side defects. What happens when you have ulnar side defect and radial side defects on contiguous, on two adjoining fingers? We can take an inferiorly based flap and a superiorly based flap. Now, this is what makes it very versatile. But of course, we need to remember the distance between the base of these two flaps. Now, you can make out that the flaps have been raised. There is a good enough about 1.5 centimeters between the two flaps and you can get a good result. Now, when you take multiple abdominal flaps, remember, you are going to close the donor side primarily. So in that situation, that is why I said, if the defect is at or just distal to the proximal phalangeal region, only then you can take this. If it is too close, then you cannot get the space between the two flaps. So you cannot do a stepladder abdominal flap or a louver flap in multiple defects which are involving the proximal phalangeal region. So we need to mark all the flaps and there are certain steps in the execution that I shall just show you now in a video. All these points I'll show in a video. Now look at this. The flaps there are multiple defects. The flaps are marked. After marking the flap, this is the cephaladmost flap that has been marked. After marking this flap, you're going to mark all the flaps, all three flaps before you start your surgery. That is like we always do. Once you have done that, there are certain differences. Raise the cephaladmost flap. I told you it need not be full thickness. You can take it just up to the dermis. And always remember, we have to close these primarily transversely. That is very important. If you close it vertically, the flap will become turned on itself. After raising the first flap, make sure it is comfortable and replan the flap for the second defect. You will find that there is a difference. Now you will find that this was the marking that we had originally made. But remember, after raising the first flap and closing it primarily, this skin will move. So now if you take it as per your original plan, you will have a problem in sighting the fingers and they will be in a very uncomfortable position. So you have to replan and then raise the flap again. So now the second flap has been raised. The same way to be done is you should close it primarily. Next, the replanning is done for the third finger and that is marked. Here you will find that it goes on to the thigh region. That is not a problem at all. Going on to the thigh region is not a problem. You can always, you don't have to struggle to close it. You can put a skin graft over it. So it is also safe in children. For instance, this road traffic accident in a child, you can make out the multiple defects and the parabolical flap has been taken for the thumb. Usually we take the groin flap for the thumb. Here the parabolical flap has been taken for the thumb and reconstruction has been done. So now this is the result. So it is safe even in children, provided the planning has been done right. There are complications that can occur. You can have a flap dehiscence, which is always due to improper positioning, and flap necrosis, which is due to improper planning and improper debridement. Debridement is very important. It is important in any any injury management, more so hand injury, because ultimately the healing of the wounds is going to translate into function. There you have to be we need to be very careful to do a good debridement so that we get a good skin cover and of course finger stiffness that can develop. Now look at this. This flap had not been planned comfortably. So there was a little deviation, but this deviation can be corrected post-operatively after the division by putting it straight and giving a splint. So that can also be corrected, provided we realize the problem is there, it can be corrected. So we shall now see an algorithm for management of multiple finger defects. If it is 2 fingers distal to the proximal phalangeal region, we can do what is known as a type 2A reconstruction. Type 2A reconstruction meaning you can take flaps from the same hand itself. That is intrinsic flaps. 2 fingers defects proximally up to the proximal phalangeal region, we do a type 1 reconstruction. If the defect extends up to the more than the proximal across the proximal phalangeal region, we cannot do distant flaps, we cannot do intrinsic flaps. We always need to go in for type 1 reconstruction, which is converting all the defects into a single defect and covering with a single flap. And then if there are more than 2 fingers, it is not ideal to use intrinsic flaps. When the defects are distal to the proximal phalangeal region, we need to go for type 2B, which is the stepladder abdominal flap as we have seen. When it is more than 2 fingers and the defects are extending into the proximal phalangeal region, I told you whenever the defect extends to the proximal phalangeal region, it is not at all comfortable to do a stepladder flap. So it is always ideal to go in for a type 1 reconstruction where you convert it into a single defect. And lastly, when it is combined with defects in the hand, when there is a raw area on the palm, then you need to go for a type 2A or a type 2B reconstruction. So what we have seen is the causes of such defects. We have seen trauma, electrical burns, industrial accidents. Factors to be considered during reconstruction, planning and execution are most important. And reconstruction options type 1, type 2A, type 2B. And algorithm we have seen. Now, if there is time, we'll go for case discussion. Otherwise, we'll go at the end. I'll ask our moderators.
Thank you, Dr. Karthikeyan. That was exhaustive. Though the brief for this meeting was case presentation, I think we started with a didactic lecture, but I think we'll take it because it covers almost all the common presentation that we see in the finger injuries. Dr. Hari had a question for Dr. Karthikeyan. Would you ask Dr. Hari, please?
Yeah, please.
So what do you do if the nail bed is intact, so if you have a shaved off defect like you presented,
Yeah.
do you remove the nail bed or you retain it and sort of come back? So what is your...
Yeah, so that's a very interesting question. When you have a nail bed is intact and you have got a defect all around the finger, you mean? You've
Yes.
got a defect all around the finger, but the nail bed is intact and the terminal phalanx is intact.
Yes.
Now, we can very comfortably give a flap, but we want to somehow protect that nail bed there so that the nail growth can be good. So what we do is we give a flap cover circumferentially. But when we do that, the undersurface of the flap will stick to the nail bed and cause synechiae and scar formation, as a result of which the nail growth that is going to occur, either it can get macerated or the nail growth that is going to occur is going to be scarred and deformed. So what we do is we apply a skin graft over the nail bed upside down. That is, the epidermal side of the skin graft will be facing the nail bed. We suture it to all the sides and then give the flap cover. When that is done, the undersurface of the flap will stick to the dermal side of the skin graft and stick over there, protecting that nail bed from further scarring. Then we divide it, we remember this and re-release the nail bed and allow it to grow.
Yes. Mute. Pankaj is muted.
Dr. Jindal, you have any questions for Dr. Karthikeyan?
One question. I know we are slightly overstretching it. I remember Dr. Tombekar one word, because once we do this flap, there is some color mismatch. It's, of course, you can always debulk it, but he used to call it digitus obnoxious. And some people have come back to have it amputated because it is bulky, it is discolored, and people make joke out of the finger.
Yeah, I agree with you 100%. The color match is very poor. And of course, as far as the bulk is concerned, we can always thin it, as you said, but the color match is always a problem. What we have done for a few patients, very few patients requested for this, a lot of them asked for it, but some of them insisted. So what we do is we excise that skin over it and apply a full thickness graft from the insole of the foot. So that gives a better color match than what they had. Even the insole, when it looks very good when it is being applied, but with time, even that gets a little hyperpigmented. So I think the search, maybe the microsurgical option is maybe the only other option which can give you a good color match.
So you have also encountered this mismatch and people not finding it acceptable.
Yes, definitely. And especially we have seen sometimes the groin flap or the thumb, when it is very bulky, it hangs out like that. They beg you for amputation of the finger. They say, rather have no finger than have this thing hanging over here, especially when children are concerned. They say, my friends in school are making fun of me saying I have an extra penis in my hand. So they are very ashamed. So they always keep their hand in their pocket and they beg us for removal of the flap. These are certain things we have to keep in mind. I suppose we take this momentum forward as we go and try to keep refining our techniques.
Yes, absolutely. This is very important for us to know, not only for us to know, but the patient should also know. Having undergone this extensive reconstruction of at least being in the abdomen for 3 weeks or so, and then debulking, and after 3 months, they say, it looks rubbish. We want an amputated. So the frustration just comes down to us, doctor, you have wasted our time. So we have to warn them, if you want saving it, yes, these are the options 1, 2, 3, from free flaps to groin flaps, but color mismatch will be there. So if you go for this groin flap or one of these abdominal flaps, they're extremely important, because 3 months down the line, if you tell them you're going to amputate it because it is not like socially, then it's extremely embarrassing for everybody. Thank you. We go on to, I think, the next presentation because we are running short.
Sure. Dr. Karthikeyan, we'll of course come back to certain aspects of these finger injuries. One of the challenges that we have found is giving a one-stage solution to these injuries, because a lot of these injuries are laborers, they are migrant laborers, and they typically would not want to undergo a series of procedures for reconstructions. So that has always been a challenge in treating industrial injuries. So these seemingly small injuries do pose a significant challenge, and if time permits, we'll come back to some of your case presentations. May I now invite my co-moderator for this session and hand surgeon par excellence, Dr. Pankaj Jindal from Pune, to talk to us about certain very specific aspects of hand injury, like a punched out hand and some other common industrial hand injuries. Over to you, Dr. Jindal.
Thank you. Thank you, Pankaj, Ahire, Doctor. Having heard a bird's eye view on multiple causes of injury from Professor Karthikeyan, I go on to two specific cases, time permitting. Am I visible, Dr. Ahire? Is slide?
Yes, yes.
Okay. So we'll go to one of this industrial injury. 30 years old gentleman, industrial worker, had a punched out hand because of a molding machine here. And we presented, this was the volar defect on the, and this was the dorsal defect he had. The glove he was wearing contained all the punched out structures, namely the bones. And what were the bones? The third and fourth metacarpal phalangeal joint on the proximal phalanx here. The tendon, the flexor and the extensor tendons, the common digital nerve and the proper digital nerves. And this was 10 in the night when he presented. So what should be the aim when you see these patients here? Whether it is just healing of the wound or something more, restoration of hand function here. What's not moving?
Yeah.
It's not moving. Okay. So what are the options at this stage? Shall we leave it alone? Shall we attempt suturing this wound? Or shall we reconstruct whatever is lost? I opted for a reconstruction here to this patient here. So after debridement, I fixed the metacarpal back here. The fourth metacapophalangeal joint at the proximal phalanx base as a composite graft. This was put back here. To cover the defect, I raised two flaps here. On the volar aspect, this was the flap based on one of the branches, the dorsal branch of the ulnar artery. This was raised to cover the volar defect. While on the dorsal aspect, primarily in the night itself, we covered it with the posterior interosseous artery flap here. So having covered everything back, this is the kind of hand function we were able to restore at the end of the treatment here. The volar defect went on to good healing. The dorsal defect went on to a good healing as well. Now, when we are considering the options, shall we leave it alone? Now, if we leave it alone, we'll have floating fingers here. The middle finger and the ring finger will be floating because there is no support coming from the metacarpal 3 and 4 here. Whereas if we attempt suturing, this is just not possible here. So instead of using 4-0 or 5-0 or 6-0 ethylon, probably we'll be using number 2 or number 1 ethylon here. And in the process, what we are going to do, we'll end up strangulating and damaging more skin here. So again, attempting suturing is probably going to be counterproductive here. And therefore, once we go on for a reconstruction, we have to follow 5 cardinal principles. If you try to make a shortcut, you are going to end up in big trouble here. And the first one is debridement. Second is skeletal stabilization. Third is primary repair of tendons, nerves, and vessels, as and when required vessels. A skin cover, to which Professor Karthikeyan has just elaborated extensively here, and the rehab. You do number 1, 2, 3, 4, and if the rehab is missing, you can guarantee a very stiff and useless hand here. And therefore, rehab becomes extremely important here. Once you do embark on any open wound, it's important you do this in the same theater where you are doing your radius ulna, because this concept of a side theater, a septic theater behind a curtain is an absolute no-no. This should be shunned. This should be banned. This is absolutely nonsense. This is very important to have appropriate instrumentation from small instruments. You can't use the same instrument that you use for fixation of femur and radius ulna. You need small instruments here. You need appropriate magnification of loop or microscope and a tourniquet, which is effective, and a pneumatic one here. To do all this thing, it requires time, patience, and an intense desire to restore the hand here. Coming back to the first one, debridement, it is essentially converting a contaminated wound into a surgically clean wound and requires a lot of washing, removal of the foreign material and all the dead material here. Sometimes this requires hours of cleaning here under appropriate anesthesia, tourniquet, and using small instruments here. It is just not pouring a spoonful of hydrogen peroxide and seeing frothing that it's going to end up in a debridement. It doesn't work. And nor is debridement, antibiotic is a replacement for debridement. Debridement means removal of all that is dead and all that is foreign here. Debridement becomes an absolutely essential foundation for a successful outcome here. A lurking infection will ruin a perfect reconstruction here. And this is a time spent, hours of sincerely converting a contaminated wound into a surgically clean wound is a time well spent. It's worth the effort here. Coming to the second principle is stabilization of the skeleton. You have options of plaster to K-wires to place to external fixator. Of all the choices that are available to you, the most important thing is choose the option which is going to minimize stiffness, which is going to allow you early range of motion here and will allow an easy, unhindered access to the wound here. But most important thing is, howsoever you use it, you have to put it appropriately so that you get in the end a very stable fixation so that you can mobilize your joints early here. Coming to the third part, repair the tendons, nerves and vessel primarily here. You're going to do it later, the later never comes, and therefore do it primarily on the day of arrival and the patient is on the first time when the patient is on the operating table here. Fourth thing, again, Professor Karthikeyan elaborated here. Try a primary skin closure. If you can't, consider skin grafting or a flap. But there are times when the skin is not available. In those situations, do not wait for granulation tissue. Granulation tissue is waiting and inviting infection. And inviting infection is beginning of the end. And therefore, do not wait for granulation tissue because that's healing by secondary intention here. On the bare bone, do not consider a combination of granulation tissue plus skin grafting because that is not going to work, especially in this situation that is under consideration right now here. So when do you put a flap? The moment you have a white structure exposed, you require a flap. A white would mean a bone, a white would mean a nerve, a white would mean a vessel, a white would mean a tendon without a peritoneum. Again, to reiterate, do not wait for granulation tissue here. Prepare a vascular milieu. A vascular well-perfused bed and a vascular well-perfused roof is going to be the mainstay of having a good healing of the wound here. So having put these back, the metacarpal phalangeal joint here, the common digital nerve, the proper digital nerve, the extensor tendon, the flexor tendon, we put back everything after debridement, covered it on the volar aspect with one flap and the dorsal aspect, another flap. Having achieved the four considerations, after considering these four things, the fifth part was the rehabilitation is. The most important thing is in hand is avoiding edema here. Do not put strangulating sutures, prevent venous engorgement here. And if you have a dependent position, you are again inviting trouble and having a stiff hand. You are going to have an edematous hand, a swollen hand. A swollen hand is going to be a stiff hand and therefore avoid a dependent position here. Even if you do a good surgery, important thing is see the patient, the wards here. The moment somebody in the ward puts a knot here and suspends the hand in the air with a sling, it is dangerous and harmful. Probably all structures distal to the sling is going to become edematous. And therefore see to it, you don't get a strangulation while the patient is in the wards here. Again, I am not very comfortable with these slings because that forces the hand to be in the dependent position. And by the end of the treatment, the shoulder becomes stiff, the elbow becomes stiff, and therefore avoid a sling here. Instead, it is not very easy to start with, but persuade the patient to keep the hand elevated above the heart level here. Coming to the next common problem that we encounter is putting a plaster on the volar aspect with the MP joints, IP joint all extended. The moment you have the wound heal in 2 weeks time, 10 days time, and trying to make the people flex a finger becomes more difficult and challenging. And therefore avoid a volar slab with metacarpal phalangeal joint extended here. Avoid a volar slab, prefer a dorsal slab so that your MP joints majority of times are into flex position here. The sprints, I'll not go into the detail, it's a subject in itself here. Coming to the next part, can you improve the function of this hand further? Yes, of course. There will be tendon adhesion. You can tenolyze, you can do a tenolysis of the structures involved, whether that be a flexor tendon, extensor tendon, or both of them, so that you can augment the range of motion here. But the problems are there. most of the patients coming to you will be somebody who is a migrant, who has come thousands of kilometers away to your city and looking for a job here. So the moment they sustain this kind of an injury, the social system, which is already bare, is lost. He loses his job, he loses his house, rented house, and he has no support system. And again, even though it may be a small amount, the travel arrangement is scarce, and the cost involved is nobody is ready to support. And therefore, somewhere you have to stop the treatment. And if the patient is comfortable with whatever has been achieved, we have to stop the treatment here. Even if the financial support for treatment is taken care of, something which is still not supported is taken care of, and therefore decision making is finally in the hands of the patient. So once this wound healed, the patient returned to his hometown and therefore was lost to follow up here. Is it something unique? Yes, it's not a very common injury. A similar case had come in Journal of Hand Surgery in 2016, where a similar punched out hand was presented. But here, the surgeon opted to dissect out the PIP joint and reconstruct the metacarpophalangeal joint. At the end, amputing the small finger. This skin overlying the middle ring finger was used for coverage of the defect here. But I would say probably a uses of a flap as shown here would have helped the patient save his fingers as well here. So this is another comparative study that I found, a comparative case presentation I found in the literature here. How much time I have, Dr. Ahire? I think I'll stop here.
If you have a case to discuss, sir, we can go ahead. I think it's important to discuss cases.
So you want to? I'll stop here, right?
So if you have a case to discuss,
yeah,
sir,
I have one more.
Ahead.
Yeah,
yeah,
sure. Okay,
you can go ahead. Hello.
Am I visible?
Yes, sir.
Okay. Sorry, I've come back to first slide.
So if you want to pose some questions to the panelists, you can do that.
Yeah, please. Any question for me?
If you want to put a case for discussion to the panelists, that also you can do, sir.
Okay, I have another case here. Again, Professor Karthikeyan has showed about these cases, but again, this case is presented because of the problem that are commonly encountered by quite a few of us here. Now, what do you see here? This is a 32-year-old male, sustained a press machine injury and presented 3 days later to us. The wound is, I won't say it's an isolated sutured wound, thick sutures here, strangulating sutures, and what you notice here, signs of ischemia in the form of blisters here. This is the volar side of the same problem. Wound is sutured up here, and the blistering and the finger is turning dusky and dead. The aim in such situation is save all possible length because the 2 digits are already lost here. So as I said, if you follow this 5 principle, that's become the crux of any treatment of an open wound here. Here, of course, critical stabilization was not the consideration here. First thing was debridement and skin cover. So with debridement, after removal of all the dead tissue here, and this is the kind of defect we encountered in this patient here. There are various options. I'll not go into the details here, but there are options available. Professor Karthikeyan dealt with it earlier here. But decision making is important here. It's as in his words, it was combination of 2AB here. But what sequence you have to put in these flaps? Because the fingers involved are multiple, and therefore multiple flaps are to be raised here. And therefore planning and sequence of execution is important in this situation here. So we debrided it here. So what were the options here? Cross finger flap? Probably I'll not be able to take my small finger here. A thinner flap? Probably yes here. A free flap? Of course, that's a possibility here. What about this stump of the middle finger here? Yes, this was easy. So this is probably the only thing that is required here is a transposition flap here. What about the index finger? A cross finger flap? Well, there is no flap possible from this finger. Thinner flap? Yes, but this finger is too small because it's amputated already at the level of the distal interphalangeal joint here. Reverse flow flap? Yeah, that's a possibility here. A free flap and syndactylized with a distant flap, as Professor Karthikeyan has said. Yes, that's again a possibility. What about the thumb? Again, you can do the transposition flap. You can see a small cut from here. So again, so for these two fingers, the thumb and the middle finger, we opted for a transposition flap here. Now, what about the index finger here? Index, we raise a reverse flow flap here from the base of the proximal phalanx and brought this flap to cover the defect on the tip. And thus we were able to save it. Were we? Let's see here. Now, so flap is covering the stump of the middle finger, the thumb is covered here, and the index finger is also covered with a reverse flow flap from here. Now we have a defect on the ring finger, which is extending almost, it is not circumferential, part of the skin on the ulnar side is intact here. The extensor tendon is, the extensor tendon, by the way, were damaged here. There is some damage to the extensor tendon here. They are bare. They cannot accept, as I said earlier, white structures do not accept a split thickness skin graft. This requires a flap. There's a defect on the radial side, so I covered with a thinner flap here. So we've got a good coverage on the dorsal aspect, on the radial aspect here. So this is covering the reverse, the index is covered, the middle is covered, and this is covered as well. So what happened in the end? The index finger, we could save the length. The middle finger stump was covered with a transposition flap, and this you'll appreciate we were able to save the middle phalanx, and a flap is nicely covering the dorsum and the volar aspect I'll just show here. Now it looked huge to start with here, but once you insert the flap here, you save a length here, you save a length here, and the defect on the thinner area can be covered with a split thickness skin graft here. Secondary surgery, yes, we have to restore the, it is not flexion contracture the PIP joint here. The patient had an extensor tendon injury, and it has almost been 1.5 years since the patient was operated, but 6 months COVID, this has been delayed, but this is passively mobile here, and sooner or later he'll be a candidate for a PIP joint extension here. So yes, they do require some secondary surgery in the form of tendon reconstruction here. In summary, if the skin cannot be approximated, please leave it open or consider options like some kind of a flap here. And if the bone is exposed, cover it with a flap. Thank you very much, all the audience, for patiently listening. Any question for me? I'll stop here. Thank you.
Yeah, so there are no questions on the from the audience yet. I have one question, sir. I think one of the most challenging things which I find in the crushed fingers is the extensor tendons. We have almost a standardized approach to flexor tendon reconstructions and primary repairs. However, we do not have such for the extensor tendons. I have always regretted not addressing the extensor tendons primarily. And whenever I attempted to deal with them secondarily, it has never given a satisfactory result. So would you advocate a very aggressive approach of addressing the extensor tendon repair or grafting primarily when you are dealing with the crush injury itself, especially in the fingers? May not be in the palm where they are tubular, but cylindrical, but especially in the fingers.
Yes, all patients will attempt a primary repair of the extensor tendon if and when available. As and when it is not available, I'll put either a graft or I'll take the central part of the extensor tendon, reflect it distally, so that if this is my finger here, I reflects the central part of the extensor tendon distally here, and the flanks are sutured back here, and this becomes a reconstructed part of the defect here. Have I been able to convey? So I'll do it, yes. And the second part, if this is reconstruction on the finger, it's important you immobilize it for at least 4 to 5 weeks there, because if you don't immobilize, the tendon gets stretched over the fingers here. Yes, some of these patients will require a tenolysis 6 months down the line, but that's an option available to us at the end instead of doing a secondary tendon grafting.
So whatever, whether a repair or a reconstruction, a primary attempt will give a better outcome.
Yes, I would do it primarily.
Perfect. Thank you very much, sir. Thank you for your presentation. May I now invite Dr. Hari Venkataramani, a dear friend for more than 2 decades. Many years ago, we worked together in Ganga Hospital, and And Hari has gone on to become a world famous personality in limb reconstruction and brachial plexus surgery. Hari is now going to speak to us about approach to a mangled upper limb. I think perhaps the highest number of mangled limbs that are getting operated in the world today could actually be in Ganga Hospital. And he must be witness to many of those, if not all. Over to you, Hari.
Thank you, Pankaj. And actually, Dr. Jindal very beautifully presented the cardinal principles. And he's from the same school, Louisville School, like Dr. Sabapati. So what I will be covering is also the quite similar. So as you mentioned, I will present one case and also illustrate all the principles you need to follow in that particular case. Sorry, yeah. So this is a lady, she's a 19-year-old girl, first week at work. We always find two categories of patients who get very massive injuries. One is very early to work, that means they just joined the duty, or of course migrant laborers, as was mentioned in the previous talk, because they are very enthusiastic in working. And of course, we see these injuries less and less because of high industrial safety practices. But still, yes, because being a tertiary center, we do see this. So this lady presents to us like this. As you can see, it's a mangled upper extremity. The hand is though viable only based on the radial artery and the radial skin bridge. So as sir mentioned in the previous talk of 5 cardinal principles, I have taken the 10 commandments from Dr. Sabapati's talk in the ISSH, where he presented on the approach to a mangled upper extremity. So this is the X-ray of the same girl. As you can see here, there is extensive forearm mangling, as well as damage, segmental fracture of the ulna, and multiple metacarpal fractures and disorganization of the hand also. So first of all, as a trainee, as a junior surgeon, when you see a hand like this, first of all, what we say is take a deep breath, think calmly. However bad the situation may look, there is always a way out, and keep thinking, how can you get it all right? The first patient who sees the hand has got a very significant role. And that is why now in our department, as you all know, that it's a consultant around the clock available, and we do calls staying at the hospital. So it's very important that the first person who sees his hand, he plays a very significant role. Otherwise, many of these can end up in amputation. And if you're not sure what to do, please call for help early. So the first principle is that you shall make a complete plan. And this is very important. A plan from start to finish and then work backwards. So how do you plan? So in this, as was in the previous case, first we need to know what all is damaged. So soft tissue, bone, and functional tissues, which are the tendon, nerves, and vessels. So when you make a plan, you need to make a plan for all the 3 components and then start working on it. If you don't have a full plan from start to finish, you need to really rethink on the salvage plan. Because if you're not able to take the plan to completion, then you will end up in a limb which is non-functional and which may be a disastrous situation. So the best situation here is you need to get help as soon as possible, or refer to a place or a secondary or tertiary center where it can be handled. Because as I said, the first person who sees this plays a very significant role. Now coming back to our lady, so this is her anterior, that is the volar side, and on the dorsal side. So the second principle, whenever in doubt of salvage, make the final decision only after debridement. And this was also mentioned before. So you need to don't decide on amputation till you debride. So do not amputate till you debride, because once you give a block, and start debriding, you will find that there are a lot of useful structures which can be finally useful for making the hand functional. So keep thinking while you are debriding, and also always keep in mind and think how function can be restored. And you need to debride very radically. And what you need to keep in mind is the white structures, as was mentioned, the white structures being the nerves, tendons, vessels. These are the structures where the debridement should not be very radical. That does not mean if they're damaged or injured and contaminated, you don't debride. You have to debride, but be a little conservative. Whereas when it comes to skin, you can be more generous in clearing up and removing all the non-viable tissue. So if you see the amount of tissue which you have debrided, we need to skeletonize the structures. So that way what will happen, you leave the tendons, the nerves, and the vessels long for subsequent reconstruction and remove all the distally based muscle, as has been done here. When there is an opportunity to augment blood supply, you should always do it. In this case, because the radial artery was intact and we were planning a free flap, so we were not doing the ulnar artery. But otherwise, whenever there are a lot of degloving and the skins are avulsed, it is always nice to augment the blood supply. So whatever vessel you can repair, that is ulnar, radial, or even any branches which is going to the degloved skin, it is always nice to repair it. Now coming to skeletal fixation, that is the foundation of our reconstruction. So in our unit, as we know, all the fixations are done by our expert orthopedic trauma team. So in this lady, because there was a segment fracture of ulna, straight away we decided to go for one bone forearm fixation, and that is how it was done. So one bone forearm fixation was done. We should always aim for very stable fixation, and we should avoid any non-union. So the way you can avoid non-union, number one, you do a thorough debridement of the bone. Number two, you do adequate bone shortening so that you get good bone ends together. So having done that, now we shall provide soft tissue cover. Again, if you leave it too long, ideally a soft tissue cover should be done within 72 hours. And concept of an emergency free flap is when you do a free flap or when you do a flap cover within 24 hours. So ideally, you should try to do it within 48 hours to 72 hours before the tissues get desiccated and there is secondary loss. In our unit, as we have seen the extent of debridement which we have done, usually we don't do secondary or repeat debridement because we have already removed all the tissues which are non-viable, which have hypovascularity, and all the foreign tissues which are there in the wound. So having done that kind of debridement, this is at 48 hours, we have done an anterolateral thigh flap. Coming to the flap, as we saw in the previous two talks, you do what you are good at, because every type of flap cover or every type of reconstruction can achieve the good result in your hand. By regularly doing the same thing, you increase your operational efficiency, reduce the cost and complication. Our philosophy is that the type of flap has no bearing on post-operative infection. Only thing you need to remember is try to do it as early as possible, and also try to do a flap keeping the future access and cosmesis in mind. So you should not be doing a flap which is very bulky or cosmetically disfiguring. Also, the flap should have access for future. As you see here, we need to do future multiple reconstruction in this girl. So our choice in such situation is to do a skin flap. Now, having saved the limb, if you see here, it does not look good. There's one bone forearm, but the whole wrist is tilted to one side. So again, you should start thinking of improving the function. So this is very important, because if you leave this hand in this condition, then the whole reconstruction will get a bad name. So now you get the secondary procedures. So when you do the secondary procedures, you need to keep the sequence right. So here, first we need to restore the sensation. So we have done a secondary median nerve reconstruction. And because there is a long segment ulnar nerve loss, so what we have done a side end-to-side reconstruction. We have taken a small fascicle from the median nerve and put it to the ulnar nerve. So this will restore the sensation in the little and ring finger. Along with this, what all we have done is we have done the arthrodesis of the MP joint of the thumb, arthrodesis of the PIP joint of the middle finger, and also the ring finger PIP joint. And then Dr. Praveen Bharadwaj helped in this case. So if you see here, the whole wrist was tilted and the forearm is not in good position. So we do a corrective osteotomy. So derotation osteotomy of the forearm was done. And then the wrist was fused on the ulnar side. And also we did a subsequent fusion of the CMC joint of the little and ring finger. So once having done that, you see, this is the kind of reconstruction we were able to achieve. At all times during the reconstruction, you should keep your aim in mind. And the aim is the thumb must meet the fingers. Do whatever you can to achieve this. As long as the thumb meets the finger, the hand is functional. So this should be our fundamental aim whenever we reconstruct any forearm, hand, or any upper extremity injury. So this is what we call as the global function of the upper extremity. So this is the same girl. Of course, the time gap between the first surgery and this result is nearly around 2.5 to 3 years. And we were able to do many of the surgeries under the government scheme, under the free scheme. So you can always help the patient in trying to maximize the resources and trying to get the hand function all right. So if you see, this is from the beginning. So that's at the end. First picture is at the salvage, then at the secondary procedures after the nerve reconstruction. And finally, if you see, improved function directly improves the confidence level. You need to keep in mind that in hand, unlike other parts of the body, aesthetic outcome or aesthetic function is basically called as dynamic aesthesis. So a hand which is functional, which works normally, is actually a beautiful hand. So that is what we need to keep in mind. And that is what we were able to achieve in the end. Now, as a bonus, a second, just exactly similar case, but the only thing is here, we have done a revascularization and we have done the same principles, shortening of the bone, reconstruction, primary ALT free flap. And if you see here, metacarpals, we have only used K-wires and a very stable forearm fixation. And all these cases, outcome can go either way. That can be a poor outcome or you can have a great functional outcome. And it all depends on keeping these 10 principles in mind. And then you should always take or seek help. So all three of us were involved in this salvage and to get the functional restored. So wherever you are, your capability is lacking, there is honor in seeking help, and there is honor in seeking help early. So this is very important to do that. And always believe that you can get a good outcome. Trauma is one situation where the patient totally does not know what he is in for. He does not know if salvage is possible. Don't know what exactly the outcome would be. And as surgeons, it is our duty to guide the patient in decision making. Thank you very much.
Thank you very much, Hari. Dr. Rajendra Nehete has a question for you.
Yes, please.
Hari,
yes.
When you did the derotation osteotomy for the single bone forearm,
yes.
The primary setting when we are doing the single bone forearm,
yes,
what position would you propose to give?
Actually, ideal position for a one bone forearm is a mid-prone position. That's a functional position to have. That's what was aimed at. But as you know, in emergency situation, it was kept at that. But over a period of time after the flap and everything, it again rotated into a hyper-prone position. So that's what we wanted to correct. So it was actually brought down to a mid-prone position by the derotation osteotomy.
Okay, and it is always a proximal ulna and distal radius.
Yes, yes, yes.
You can do the reverse manner.
There are situations where the ulna is totally missing. You can do a radius to radius. We have also done that. And that is actually sometimes more functional. They can do a flip of the forearm and get a pronation and supination. But classic one bone forearm is a proximal ulna to distal radius.
Okay, thank you.
Are there any questions from any of the panelists? Dr. Jindal, do you have any question for Dr. Hari?
No, that was a really nice presentation.
Yeah, Hari, while we know what are the determinants of good outcome, as you outlined, what are the potential pitfalls where you could expect a bad outcome?
Yeah, so every step, the first step is that not taking a right from decision making. So first decision making is that if you are not confident that you can achieve the end result, what will happen is you may do a suboptimal debridement, suboptimal fixation. So things which could have gone wrong here is not debriding and removing all the muscles, not shortening adequately, not doing a stable one bone forearm fixation. Otherwise you will put an external fixator, and unstable fixation to start with is a disaster it's a disaster, because if the joints and the forearm is mobile and you're doing a flap, then that is what causes infection. There are two reasons why infection sets in any industrial accident or any road traffic accident. Number one is that you leave behind tissues which are hypovascular, that is poor vascularity, number one. And number two, you leave behind bone which is bare of periosteum and which does not go for primary union. So this bone, even if you cover with a flap, there will be a discharging sinus. So I think our aim should be to achieve a primary bony union. I always say plastic surgeon's aim should be achieve primary bony union, and an orthopedic surgeon's aim should be achieve a sinus-free wound healing. I think that totally sort of, so every step you could have gone wrong in poor debridement, poor fixation, choice of flap cover. If you see here, we have done an anterolateral thigh flap. It's a huge flap. If you had done a big abdominal flap, it would have scarred her abdomen because she's a young girl. Primary closure of the donor site was also done in this lady. And then, so flap cover choice. And finally, the secondary reconstruction actually played the very important role. Because unless you bring the hand in a functional position where she could meet the thumb could meet the fingers and in a mid-prone position, all this would have gone waste. So if you leave behind at that stage and not go in and or step in. So at that stage, we need to subsidize them. We need to actually, a couple of surgeries were done free of cost. So unless we do that, these people will go into the society and get a bad name for the reconstructive procedure rather than getting any good name for us, because people will only see the hand. They will not see how she was when she had the injury. Mute. Pankaj, you're muted.
Thank you very much, Hari. That was fantastic. Now it's my pleasure to invite young face in hand reconstruction scene, young member, Dr. Joshit Balan. He does the fantastic microsurgeon, posts very interesting cases on our chat groups. Joshit Balan from which hospital are you working in, Joshit?
I am working in Elite Mission Hospital
Institute. Wonderful. Please go ahead.
Yeah. Thank you, sir. Thank you very much, sir. First of all, I would like to thank ISSH, MOA, BOS, and all the faculties in our group now. I will start my topic directly. My topic is on machine injury amputation, major amputation, how you approach. So the goal of upper extremity replantation is preservation of the function for independence and preservation of the and prevention of chronic pain. And the machine crush injury always have a huge element of crush injury. Along with avulsion, there will be tissue loss and there will be gross contamination. And initial step, I will go through some of the basics. Initial step will be to control bleeding. You can use a tourniquet, digital pressure, or you can put clamps, or we can ligate. If you are ligating, you have to try to keep maximum length, preservation of the length of the vessel. And you are not supposed to use tourniquet for a long period. That may also hinder the distal vascularity of the limb. And you have to get a venous access and start crystalloids, and if required, we have to arrange blood. And proper tetanus prophylaxis, antibiotic prophylaxis, and adequate analgesia is another important thing for the patient. And whether to replant, first important criteria is the hemodynamic stability of the patient. Patient should be stable. The amount of crush avulsion of the distal part and the stump of should be good. And the next important thing is the ischemia time. It is around 6 hours of warm ischemia in case of proximal amputation, since there is major muscle groups are there. So, and if there is a multiple level injury, that it is questionable, and condition of the vessels and the other medical comorbidities of the patient. And another important factor is that motivation and occupation of the patient. If the patient is not motivated and doesn't want the thing, you don't go for a replantation. And last thing is the expertise of the surgeon. And we have always think that life over the limb, because one movie is there 127 hours. In this movie, one climber or a trucker is trapped his upper limb in a bolster in a canyon, and he was trying to take out his limb, and after a long time, around 127 hours, he has decided to amputate and save his life for this limb. So he is living his life without a limb with his life. So we had to always think that we had to save the life rather than saving the limb. And once you start decide that you are going for a replantation, you have to get a good adequate X-ray of the proximal and distal amputated part to look for any that magnitude of injury. And next thing is the local examination. You have to proceed with this local examination adequately be done in inside the operation theater. You have to take the part inside, and we have to thoroughly wash the amputated part and remove all the foreign body and preparation of the part for replantation. The same time, the patient should be stabilized by the anesthesia and the emergency team. The patient should be stabilized and he should be taken inside the OT and prepared for the surgery. And on-table part dissection is important. We have to meticulously remove all the dead particle, and if there is a muscle part in the distal part, that we had to debate, because that may not get vascularized once you do this revascularization. That will cause immediately there will be some waste product that will circulate back into our system, and that may cause reperfusion injury. And if the dead tissue is kept like that, that may get infected, and that will, and again, secondary thrombosis of the vessel and may cause losing the limb. So we had to debride all the unhealthy muscle and unhealthy tissue. And then we had to dissect all the vessel, nerve, and tendons. We had to try to keep the vessels, nerves maximum length possible. And we had to see the vessel, whether there is a thrombus or whether it is very conducive. That part we had to remove. And if the vessel length is not adequate, we may have to go for a vein graft. That we have to keep it in mind when you are going for a major replantation. And we had to identify and mark all the structures, volar as well as the dorsum and proximal as distal part. We had to identify and mark all the structures. We had to ligate it and mark it before going for replantation proper. And in case of a very proximal injury, sometimes already the ischemia time would have been around 3 hours and all. Then it is better to do a vascular shunting in the form of putting a small suction catheter or an infant feeding tube to just pass across the arteries and perfuse the distal part. Usually we will keep it for around 5 to 10 minutes only. And because there will be more, that venous blood is let out. So a lot of waste product which is there inside in the distal part, that also will be washed away by vascular shunting, and that will perfuse tissue, give oxygenation also. So it is a dual purpose thing is vascular shunting. The only problem is that there will be good blood loss in case of vascular shunting. So we may have to taken care about the blood bank facilities and blood for the transfusion. And once the initial step of replantation is bone shortening, that to remove the fragmented or non-viable bone and to potentially decrease the length, that shortening will potentially decrease the length of the vein and nerve grafting. And in case of wrist level amputation, you can proximal row carpectomy can be done to reduce the distance. And for forearm level amputation, we can achieve up to 6 to 10 centimeter of shortening with adequate good aesthetics as well as function. And next is bone fixation. You can do with an K-wire in case of wrist level amputation, and in forearm, as Hari sir was mentioning, it is better always to do rigid fixation. And next is the tendon repair. If the distal part of the tendon, you can do a coarse suturing. And in case of proximal level amputation, you may have to do a muscular tendinous weaving of the tendon over the muscle had to be done. And then next is the vascular anastomosis. We have to do the vascular anastomosis with or without the vein graft, and it is better to use 80 or 90 if possible. Otherwise, even 70 toluene also can be used for amputation in the proximal limbs. And once we have done the arterial anastomosis, it is actually in case of proximal limb, this one, and it is a late case, it is better to release the clamp and let the vein bleed for some time, so that some of the waste product is let out, and do the venous anastomosis later. And in case of distal amputation and in early cases, you may able to do venous and arterial anastomosis, then you can release the clamp. Only thing that we had to inform the anesthesia team that because there will be a reperfusion injury, so there will be hemodynamic collapse and there will be reduced renal output. All these things has to be taken care. We had to just tell the anesthesia team to be ready, then we are going to release the clamp. And in case of proximal amputation, it is always better to do a distal fasciotomy. Since after one perfusion is started, there is always a risk of tissue becoming edematous and go for a compartment syndrome. It is better always to prophylactic like kind of distal fasciotomy, liberal distal fasciotomy. And after reperfusion, once you reperfuse the limb, then you have to see the muscles, examine the muscles and tissue again, and we have to see whichever tissue is not viable or it is not perfused well, we have to remove it to avoid contracture, and it is to limit postoperative infection. And postoperative care and emergency postoperative care, and we have to give anticoagulation. Anticoagulation we are giving 50 international unit per kilogram heparin at the time of clamp release, followed by 5,000 international unit per day for 24 hours. And adequate hydration is another must. And we are following aspirin for a month we are giving. And and we had to monitor the viability of the hand post-operatively by looking at the clinical examination is the main thing. We had to see the capillary fill and turgor of the distal part, and we had to see, and we can see, use the SpO2 probe can be put, and this one oxygen saturation we can assess, and we have to always look for the reperfusion injury in the postoperative period also. We had, because there is a secondary ARDS formation also is another threatful thing for after major replantation, and there is high chance of vascular thrombosis in the initial 2 days, and later that chance reduces. And now I'll go to few of the patients we have operated. First patient is the 32-year-old gentleman with a distal amputation. That distal amputation with there was another distal injury was there, and which was this is all the thing has been dissected well, and the tendon repair bone was fixed with by internal fixation by the orthopedic team, and this artery, ulnar artery and radial artery has been done, and we have done all four veins in this patient. You can see this have kept in the volar tissue that skin was not coming together. So never try to close it tightly, so that also hinders the vascularity. So we have put a skin grafting over there to prevent compression over the vessel. And distally, you can see that veins are on the dorsal surface. You can see the veins are well dilated, and it is well perfusing. And this is 1 week post surgery. This patient is a manual labor from this one migrant worker, and after a month of thing, he has migrated there. And the second patient is the 35-year-old patient with wrist level amputation. Here you can see there is one digit there was a digit loss and an oblique amputation over the digit. And here we have done a proximal row carpectomy and fixation of the by K-wire. And this is the immediate post surgery. You can see well perfused limb, and this is the 6 months post surgery. You can see the good adequate function he has got after the surgery. That is extension. This is the flexion. Thumb is improving. Still, it is improving. You can see the thenar eminence. It is also becomes good, and it is nicely doing physiotherapy also. And another young adult with this is a patient from AIMS Delhi actually. This because we have not got a amputation, proximal level amputation. It is patients by Dr. Raj Manas. So I have borrowed the patient. So it has been done. And he has shown that post-operative monitoring with SpO2 Pro, and this is the 1 year post-replant status. You can see good flexion and extension is there. So because that another important thing after replantation, good physiotherapy and good cooperation from the patient is very necessary. Otherwise, you will not be getting a good result. And the final patient I'm going to present is a 45-year-old gentleman presented to us with a mid-palmar level amputation because he had a digital artery, level, common digital artery level of injury. So this distal muscle, everything has been debrided, and bone has to be enabled to keep it in alignment. And that bone was fixed with K-wire, and all the digital arteries has been repaired, and 3-4 dorsal veins were repaired in this patient. And you can see this is the 4-month post surgery, because now it is this patient has been operated recently during the COVID period. So this is the 4-month post surgery picture, and you can see this patient is started getting some hand function by 4-month post surgery, because of the COVID situation, that physiotherapy thing was also, we are not able to reassess the physiotherapy regularly. So, but still he is able to do a good get a good hand function. And before finishing, I would like to tell another thing, that how to transport the amputated part. You have to place the part in saline soaked gauze and seal it in a plastic bag and transport in an ice bag, and never keep that thing touch the direct contact with dry ice, because if it direct contact, there will be cell death happens. And while concluding the session, the goal of major limb implant is good functional outcome, and meticulous planning and patient selection is necessary for optimal function. And we have to always think that life over the limb. Rather than saving the limb, you should never lose a life. Thank you very much.
Thank you, Joshit. Wonderful work. Joshit, while your skills do allow you to salvage so many limbs, are there any absolute no-nos when it comes to salvaging the limbs? Are there cases where you would say, okay, what are your indicators which say, okay, I'm definitely not going to attempt replantation here?
Yeah, actually, because that I have already shown in this one. I'll show this one. I'll show the slide so that I'll show the slide. So because these are the rough criteria. Actually, first and most important thing is that that patient should be stable, hemodynamically stable. In a hemodynamically unstable patient, if you are planning for an replantation, that is we won't be able to save the patient. And another thing that we should be having adequate blood storage also. If you are planning for a shunting of the thing, you may have to transfuse around 5 to 7 pints of blood. In that such situation, if you don't have a blood storage and you are going for an amputation, replantation, that will lead to this lossage of the limb as well as the patient. And the rest of the things, amount of the crush evolution and the ischemia time. Ischemia time is a major part actually. If it's a very proximal injury, that ischemia part comes like 3 to 6, 3 hours itself. If the patient comes at 6 hours, is very late actually. If you try salvaging, you had to tell the patient regarding the complication, whether he'll go for after replantation, the patient have the loss of life itself. So we had to convince the patient. And the rest other things are because condition of vessel. Actually, sometimes that condition of vessel part we may be able to correct with a weak vein graft. If you put a weak vein graft and we can remove that part of vein graft, and then we have to you can circumvent that thing. And loss of tissue also. If you have a big loss of tissue, that can be covered by a flap. Actually, in case if you are sometimes in the immediate itself, you may be able to do a free flap. Otherwise, you can do this abdomen flap or something in the initial setup itself. That also can be done. But these are the things. First and most important thing is that hemodynamic stability of the patient.
So Joshi, just leave that slide on. I have a question for Dr. Hari and Dr. Pankaj Jindal. Leave that slide on, Joshi. Yeah. Of these 8 factors, do you actually extend indications in any of these 8 factors, or you are absolutely sticking to these 8 factors? Hari and then Dr. Jindal.
Okay, Jindal sir.
First thing will be the ischemia. It's extremely important. That when you mentioned about 6 hours, even 4 hours in summer can be sometimes detrimental. Whereas 4 hours probably in winter you can still accept. I remember we had a replantation in peak of June. At about 3 hours, he traveled from wherever to Pune. It perfused, but there was so much of transduit coming after 3 days also that we ultimately amputated, though there was good perfusion there. So ischemia, summer, timing, time of the year, that's extremely important. The first thing is ischemia time. Multiple level is the second thing here. Probably double level. I think Dr. Mahajan is going to speak, but I'm really not very keen about multiple level. I remember at least 2 occasions during my fellowships where multiple level injuries were replanted and subsequently amputated also.
Yeah, I think what sir said is correct, and everything is, I would say, relative. So in a small child, well preserved, we have done up to 12 hours forearm replant. But if it is warm season and not well preserved, then it's all depends on the preservation when it comes to ischemia time. Multi-level, if you have, definitely yes. What we can do is we can try to do the proximal part and do a distal forearm level amputation so that get a elbow level, elbow joint that can be done. Ischemia time can also be circumvented by removing all the extra muscle in the distal part and preserving all the proximal part muscles. And coming to comorbidity, we have done with head injuries. So polytrauma is a setting where we would hesitate. So we go by the anesthetists. If anesthetists are comfortable giving us 4 to 5 hours of time where we can do the replant, then it is fine. But if they are not comfortable and the patient is, so I think polytrauma, major medical comorbidity does play a factor. And technical impossibility, severe mangling or crush is not an indication. So I would say that everything is a relative contraindication. What is a contraindication? Maybe in one unit, in a different unit, maybe an indication. So It depends on your infrastructure, your technical ability, and your support system which you have, like availability of dialysis in case of myoglobinuria, availability of ICU facilities. So I think you need to take a call based on your current this thing. I think Dr. Nete will tell he's a single man surgeon, so his setup.
Yeah,
Pankaj, can I say something?
Yes,
yeah.
please, sir. Yes, please, sir.
I'm Dr. Nehete. As Hari said, there are all these factors can be variable depending on the setup where you are working. And sometimes I found as a single surgeon, if I'm working through the day and I finish my theater around 10 o'clock in the night, and if I get a patient at 11 o'clock, some of the indication may vary. I may not go for aggressively to replant something which I think may not survive. So there are many situations, and depending on that, you have to take a call and do it. But overall, I am also one person who will take more risk and try to replant, because losing a hand is very, very devastating for a patient. So I may err on the little of an aggressive side than on the negative side.
Yeah, thank you, Dr. Nate. Dr. Mahajan, you had a comment to make?
Yeah, I think as far as taking risk is concerned, I'll be ready to take a risk as far as the hand is lost. But a life lost is not worth the taking the risk. I think that is one thing, which we should always remember, particularly while reimplanting the proximal level amputations. In proximal level amputations, you may not get the time, you may not get the time to manage these patients, because many times I have seen the patients dying on the table right under the nose of the anesthetist, because there will be a severe hyperkalemia which will lead to sudden cardiac arrest, and which they may not be able to revive even with the best of their capabilities. So as far as the proximal level reimplantations are concerned, I would never take a chance as far as ischemia time is concerned. So we have to be very, very particular. And I think what Dr. Pankaj Jindal said, I have encountered a patient, a very tall, well-built patient with the proximal forearm level near total amputation with very well-developed muscles, and we perfused him just within about 3.5 to 4 hours. And I never expected that anything will go wrong. But then I was surprised when the anesthetist told me that his BP fell down to 60. And, but luckily we were able to save him. We didn't lose him. But then I was just wondering, if I would have lost this strong young man just trying to reimplant his forearm, I would not have been able to, forgive myself. So I think what Joshed has shown, life over the limb, so that's not worth taking the risk. As far as losing the limb is concerned, you can take a risk. We have done reimplants at wrist level or even distal level, even more than 12 hours. Recently, just 4 days before, we did one where, it was already more than 12 hours, but then it was at the mid-palm level. So in distal reimplants, there is not much of a problem. You can always take a chance. At the most, the reimplant may fail. But coming to the proximal level reimplants, I would like to, give this message, particularly to the beginners, that it's playing with fire, if the ischemia time is more. So please do keep that into consideration, that life is more important than the limb, as Joshed has, very well emphasized that. And I am a great proponent of that the life has to be saved at all times rather than the limb, whenever it is at risk.
Thank you, sir. Thank you. Joshi, do you have any particular protocol? There was a question from Dr. Hari also on this for monitoring for myoglobinuria. Do you actively watch for it, or is there a laboratory test, or how do you keep watch that myoglobinuria is not happening and kidneys are not getting damaged?
In our institute, we had to say we are looking for the renal output. And once the renal output is going down, we check for. Otherwise, the color of the urine, it changes. Then only we'll go for a myoglobinuria test. But in our institute, it's not available sometimes. So then we had to send it outside lab also sometimes. So, but still we are looking for it.
Hari, how aggressively, you manage the kidneys during major replantation. Do you
No,
preemptively manage, or you? Or
No, I agree fully with Dr. Mahajan. We don't risk life at all, number one. So we go by our anesthetists and they are very experienced. So if they say this chap is not fit, and coming to the muscle, we try to remove as much muscle as possible, number one. And in many cases, if that is the issue, the time taken is also a big factor. So I would suggest that if you are already late, don't try to do too many things in the primary sitting. Just do a stable bone fixation, do the vascular repair and basic tendon repair and come out. Don't keep on operating for long duration. So time is very important. And first sign, when you release the clamp, that is the most key moment, as all the speakers mentioned. So at that time, you call your senior most anesthetist, keep blood ready. We keep 3 to 4 units of blood ready. We give soda bicarb. We keep the monitor on and we just monitor. If on release of the clamp, if the BP drops, if there is hyperkalemia, if there is severe bleeding or severe fall in the pressures, then we again reclamp and we have even detached the limb on table because of hyperkalemia. So you can do that on table and don't take a risk going beyond that and allowing it to perfuse and in the post-operative period. So yes, you have to be careful. In a well-built, you have to always take extra precaution and be careful. And if you have myoglobinuria, yes, you have to do dialysis. And myoglobinuria post-replantation takes long sessions of dialysis. It is more than 3 to 4 weeks of dialysis which will be needed because of acute tubular necrosis also. So it is not like other dialysis where patient will come out very quickly. So we have had only 2 occasions where we had to dialyze the patient, and one was actually a simple replant, not a major replant, and the dialysis went on for nearly 3 weeks. Then he became all right.
So any role for forced alkaline diuresis before the problem happens?
So we give soda bicarb. You have to give 50 milliequals per kg body weight when you release the clamp. So just before the clamp release, you need to do that.
Okay, wonderful.
Very important. We involve the nephrologist the moment we have a patient with for a replant. The first call goes to, of course, the anesthetist. The second is to the nephrologist. We involved from the day 0. It's very important to have them there rather than when the patient has established a renal shutdown. So involve them before the surgery has even begun.
Yeah.
So places like Dr. Nehete's, where he practices as a standalone surgeon, it would almost be impossible to have a nephrologist standby in the middle of the night.
It's not standby, but he's
involved. No, whatever.
He,
even to keep them in the loop, it's not going to be easy. This is a practical issue. In a big corporate hospital, multi-speciality, it may still be possible.
Yeah, Pankaj. No, there is. I don't agree with this because the way I have been working since last 22 years, we have developed a team who's ready to work for such patients. Because they know the importance of it. Okay. So that is why we can easily manage these patients. In fact, they are ready to visit any time in the day or night also if I need them. So it's ultimately a teamwork, and it depends on how you keep your relations with your colleagues and how important you feel to treat your patients properly.
Perfect. So it's not only about skills; it's also about building the right team.
Yeah.
Perfect. Thank you. I think that's a very strong message, Rajendra. Yeah. Thank you very much. I think that was wonderful. It's now my pleasure to invite Dr. Rajendra Nehete. He's one of the most gifted microsurgeons, does phenomenal amount of trauma reconstructions. He practices in Nashik and has very wide area of drainage for crush injuries, essentially from all the farmlands of North Maharashtra. So he will talk to us about crush injuries, perhaps more focused on the farm injuries. Rajendra, over to you.
No, unfortunately, Pankaj, I did not focus on the palm injury. I have included a case which almost Hari showed actually. But then I will talk about the principles of management.
Whatever you have to share, it would be worth listening to. I know that. Perfect. Go ahead.
Welcome, delegates. This was a 30-year-old male patient with a tractor injury. You can see the equipment which is fitted on the side of the tractor.
Rajendra, you need to share your screen.
Achha, I haven't shared my screen. Sorry. Can you see now?
Yes, we can see now.
Okay. So this is I work with Dr. Chaddha, who is the orthopedic surgeon, and we do all our orthoplastic work together. So because this was the IOACON webinar, I thought it would be better if I have one case which is suitable for a combined team approach of orthoplastic reconstruction. And that is why I didn't consider the palm injury. So this was a 30-year-old male patient with a tractor injury, and you can see equipment which is fitted on the back of the back wheel of the tractor. And this patient was not driving a tractor, but he was working in the farm, and this tractor was working along with him, and his hand entangled into this equipment. And he had a crush injury of the forearm with compound grade 3B, radius ulna, and close fracture humerus because of the twisting injury. So this was an injury like this, and it is a compound trauma, obviously, with severe contamination, because whenever these people are working on the farms, it leads to a lot of contamination. Fortunately, he did not have any distal neurovascular deficit. So his vascularity was also good in spite of such a bad injury. And he had both the ulnar and median nerve intact. So I did not have to do anything for the neurovascular trauma. I'm sorry for the x-rays. This was his humerus fracture and the radius ulnar fracture. This is a photograph after lavage giving on the table. What we do is primarily we raise the tourniquet and give a lavage and then start do painting and draping. So you can see after lavage only a lot of contaminants have gone away. So what do we use for lavage? Normally 100% of the time we use a copious amount of saline, and we use a sterile tray so that when we use a copious amount of saline, it doesn't go onto the theater everywhere, because that is another problem, and because of that many people try to avoid copious amount of saline. So we use a sterile tray which is already almost always ready in our hospital and which is connected to a suction machine so that it drains directly. We don't use any other agents like hydrogen peroxide or antiseptic solution because we don't think it is useful in acute situations. Hydrogen peroxide may be useful in a chronic situations where there are anaerobic infections, but we don't use it in acute situations. Whether to use a pulse lavage or a non-pulse lavage, our preference is not to use a pulse lavage. Even if we use it at a very low pressure, and it is only by a small balloon or a 10 cc syringe. So we don't use it a high pressure pulse lavage simply because the high pressure pulse lavage, when you are using in an open wound, and especially the soft tissues like muscles, the water, the saline which is injected with a high pressure goes into the tissues and it devitalizes the superficial tissues. It may be useful in a bone, but not in the soft tissues. Secondly, the pressure of the fluid, it pushes the foreign bodies and debris inside the tissue planes, and then it becomes more difficult to debride them. So this is about the lavage. We should be very careful. And you can see after lavage, you can see only the contaminants which are stuck to the muscles. You can see otherwise all the foreign bodies and everything is automatically removed. And after this, it is very important to do a good debridement. And when you talk about the ultimate determinant of the result for the patient, I have learned it from Dr. Sabapati. He always says, one, the wound should not get infected. And secondly, all the wounds should heal primarily. So that is the crux of treating all these compound traumas, whether it is in the upper limb or a lower limb. So debridement is very vital. You have to start from the beginning. You have to remove all the foreign bodies, whatever debris and particles, foreign particles you see, remove them thoroughly. When you debride the soft tissues, you make your plan. Either you can go from center to periphery or one side to another. What I prefer from periphery to center. So debride all the skin edges, cut them off. Use a scissor and a forceps to debride, not the scoop. I've seen many people trying to scoop out the injured tissues, but it is not good. You have to debride the wound like a cancer. You go to the periphery and remove everything. He said, especially in the hand trauma, distal muscles, which are hanging on the tendons. They don't have any blood supply and you need to remove them. Tendons, you can preserve them provided you are able to cover them as early as possible. Because if you leave a tendon open and you have not covered it, within 3 to 4 days, it will have devitalized. It will be devitalized, you will have to remove it later. Intramuscular plane, you don't try to dissect the intramuscular plane on your own, but whatever planes are dissected, you just go through it. You will find a lot of mud particles, debris, and small stone particles which are driven into the intramuscular planes, and you have to remove them. When you think about the bone, if it is devitalized, obviously it has to be removed. How will you know the devitalized bone? In an acute injury, you may not be able to, but the bone pieces which are separate, devoid of any soft tissue attachments, they cannot survive. I have seen many presentations, people show the big bone fragments which they put inside and which has survived, but these are all anecdotal cases, and it cannot be always said that you will always be successful, because many times the people don't show where they have failed to revitalize these devitalized bone fragments. As Hari said, vessels and nerves, you have to be less radical and you have to try to conserve most of them. So that is about the debridement. So what we did in this patient is we fixed the humerus with the plate and screw fixation. This is another principle of orthopedics from proximal to distal. So whenever you have multiple bone injuries, you first fix the proximal bone and then go to the distal. Then for the distal forearm, look at the wound after the debridement. So this you can see a very clean wound, all clean cut debrided edges of the skin. The tendons which are devitalized are already removed. The muscles devitalized are removed. You can see a bone, but you can see on the right side photograph, the bone is devoid of periosteum. And that is where I have a doubt whether this bone will survive or not. And that is the reason we have put him into external fixator, because it was not suitable to do a plate fixation immediately. And then intermediate time. So we did not, because the bone was not good, I decided that I will not cover it immediately and wait for a little while. So intermediate time, we use negative pressure wound therapy, also called as a back dressing popularly. But the principle is, it is a temporary intermediary modality. It cannot be used in such cases as a definitive treatment modality to get the granulation and cover it with the skin graft. It is only a temporary modality, and we have found it reduces the rate of infection, it promotes the healing, and because it reduces the rate of infection, the surgical results and the ultimate result for the patient definitely improves. As soon as you get opportunity after back dressing that the wound is controlled, there is no active infection, you can immediately go for a flap cover. So this is a patient after 5 days, we removed the back dressing. You can see the bone is not looking good. So we removed the part of the ulna which was frankly devitalized, and other tissues which are devitalized, and then covered it with this. So this was after removal of the fragment of the bone, and this was the radius which was fixed into the external fixator. Obviously, all these patients, we try to stabilize the wrist also in a proper position. So now what problems remain? There is a problem of soft tissue cover. There is a problem of radius fracture with small cortical gap like a butterfly segment, and there is a ulnar defect of 6 centimeters. So how do you plan it now? So soft tissue cover and bone reconstruction either can be done one-stage procedure or a multi-stage procedure, but in such trauma, we would prefer to do in a stage procedure, wherein you do a soft tissue cover in a primary stage. So free flap cover, preferably, we always prefer in such cases. However, these defects can be managed with a big and large abdominal flaps very well. After 6 weeks, after the first stage, we plan to do a bone reconstruction. So this was a microvascular anterolateral thigh flap. As Hari said, the type of the flap doesn't have any bearing or any end result of control of infection. But we are very much familiar with anterolateral thigh flap. I've been doing it since last 18 years. And it works very well. And it achieves a good cosmesis in the forearm or extremities also. And it leads to a good healing. So when you, after the healing, after 6 weeks, when we plan for a bone reconstruction, whenever we put external fixator, we remove that external fixator and wait for at least a week so that the pin's infection is controlled if there is any infection and the pin tracks are healing. And after that, then we again remove the ends of the ulna, which were not good. And then we prefer in such situation free microvascular fibula flap. You can see the fibula harvested, and then on both the ends you will find that we have raised the periosteal sleeves, which we wrap around the fracture site so that it leads to a very early healing and it promotes good osteogenesis. As well, you can see a iliac crest bone graft harvested. We put ample amount of bone grafts across the fracture site so that these are corticocancellous bone grafts and they also promote healing to a great extent. So this is a plate fixation. You can see a good alignment after the plate fixation. And this is his post-op photograph. After this is almost 10 months now, 5 months now. You can see a good union with the radius and ulna. And this is the post-operative, a good elbow flexion, but we were not bothered about it. But this is a good hand function after that. And more important, because we have done this, he has an adequate amount of supination pronation. Doesn't have a complete supination pronation, I will say, but adequate amount of supination. So in such particular case, whenever you are doing reconstruction, it is important to follow all the principles of reconstruction in a staged manner so that we can avoid the infections and we can get the good results. Thank you very much.
Thank you, Rajendra. That was fantastic. Rajendra.
Yes.
Lavage before debridement or debridement before lavage?
Yeah, lavage is simple washing out with copious amount of saline. That we do before the debridement, even before painting and draping is done. After painting and draping done, again we do a repeat debridement, a proper debridement, but we give a lavage also after that. So basically the contaminants which are loosely hanging, they are washed away when you give a primary lavage.
Got it. Any contrarian view from any of the panelists?
No, what he says is correct. There used to be a concept that you give, we also stopped using any machine-based lavage. So simple washing first, and then you debride, and then you do a final washing. Just a couple of comments, and all others can also comment. What is the role of culture? Because that is what people keep on asking us. So our philosophy is that in the road traffic accident, in farm accident, there is no staphylococcus or Klebsiella in the wound. So most of these wounds get infected once they come to the hospital. So what you need to keep in mind is at the end of debridement, if you cover them early, there is very less chance of infection. But if you delay, then they get contaminated by the hospital flora. So all of us need to know the antibiogram of our respective hospitals, and it depends on the units where we work. Like in our unit, most of the common infective organisms are Proteus and Klebsiella and E. coli. So we need to have our antibiogram in mind. Another thing is, if you have done a very good debridement, our philosophy is also that you should not do repeat dressing before you do flap covers. One of the things is you keep on doing dressings every 6 hours but most important, it should not get soaked. So adequate padding should be there so that it doesn't get soaked, and you don't do frequent dressing changes. And that is one of the things which makes the wound to get contaminated and infected. So that is very important. If you want to take a culture before you do a flap cover, then you need to do a quantitative culture, which is not done most of the time, but you need to take a gram of tissue. And then if the count is less than 10⁵, basically it is quite safe to. So I think you should not be doing cultures. But if it comes infected from another center where it is already contaminated and there is pouring pus all around, then in those cases it is worthwhile you send a culture at the end of debridement again, and then you start appropriate antibiotics. And just one more. Yeah, just one more word about cancer clearance. When I use this word I've heard many times. So I got a very nice message for that. You should not excise like a sarcoma excision. You should do like a basal cell carcinoma with 2 millimeter margin. So that is what you need to keep in mind. So it should be a minimal excision and not a radical removal of compartment like you do in a soft tissue sarcoma. So cancer excision can have a different connotations. Thank you.
Thank you, Ari.
Yeah, very important. The dressing should not be in the wards. First, you have done debridement. If you are going to repeat, don't open it in the ward. You open it in the operating room directly, under like you're doing a surgery. Because the moment you do it, expose it to the ward, you are literally inviting a bacterial warfare there. Because that's a lot of contamination will creep in there. And therefore, do not open the wound. Go directly to the operating room, whether even you are doing an inspection, the wound there.
Yes. I wanted to elaborate one more point about this, what we do in an intermediate period. Because many times we change our plan inside the theater, and we have not discussed it with the patient and relatives what exactly we will be doing, and if there is any change in plan. In such situations, we always use a vac dressing so that we don't have to change the dressing in between in the wards or anywhere. And it really avoids the contaminants from the your hospital, and open it directly on table when you are planning for surgery, after you discuss with the relatives, maybe 48 hours or 72 hours, and you plan and do a surgery. Just open that vac dressing in theater and finish the flap surgery. So it avoids a lot of complications as well. It gives you time to again rethink on your plan whether you are rightly doing it. You can discuss it with the relatives and patient in detail, and they also come to know. Secondly, this gives them time for preparation of funding also, because I see many of the presenters talk about the cost. Cost is a big factor, but when you explain them properly about the major surgeries also. Now, if you consider as a third person, you will find that we have done two major supra-major surgeries. One is free flap cover, one is free microvascular bone flap transfer. But then, is there any other way which will avoid the number of stages and it will reduce the cost of the surgery than this? It is impossible. If we can do a two major supra-major surgeries, in spite of that, the cost is always limited in these patients. And they always will agree if it is explained properly. If you show them the previous patient's results, they are always happy to spend this amount. And ultimately, it leads to cost reduction and less complications and better results for the patients.
So can I just make a comment?
Yes.
As we said, as you were saying, we wash it before the hand is kept on the table. Then after painting and draping, we again wash it. And then after the surgical debridement, we wash it again. So I remember a saying that used to be said by our teachers, the solution to pollution is dilution. So we keep following that because ultimately we are all afraid of this infection. So the solution to pollution is dilution.
Yes.
Maybe something like an Amitabh Bachchan movie dialogue it is.
Yes, Dr.
Yes.
Mahajan had a comment, and then Dr. Joshi, you can also comment.
I think Rajan has already commented on that. As far as the contamination in the ward is concerned, I think in the intervening period, the VAC has a very important role to play, and that is what we also do most of the time. After you debride, put a VAC and then bring him to the theater. So there is no exposure in the ward. I think that's a very good policy. Only thing is the cost goes up. But then, if you do a dressing and there is a soakage coming outside, there is going to be some cross-contamination. And regarding the lavage, I think the problem is with the pulse lavage if you are doing. The simple lavage is not a problem. I mean, you can do it before, you can do it, after. But if you do the pulse lavage before debridement, then, it kind of pushes all the contaminants inside. So pulse lavage is to be avoided at any cost before debridement. If at all you have to do it, then I think you can do it after debridement. So if you do it before debridement, that will be detrimental. So, as far as the infection is concerned, I'm sure all of us are convinced that it's because of inadequate debridement always. Otherwise, if you do the adequate debridement, and you give a early cover, then the chances of infection are almost negligible. So it's we many times blame that infection has occurred, but I think the blame is usually on us or one of our colleagues who has done the inadequate debridement. So debridement is the key to avoid infection.
Thank you, sir.
Yes, my comment is on VAC itself, sir. The thing is that sometimes in a major crush amputation, there will be some deeper pockets will be there. So if it is near the vascular pedicle or something, and if you are putting a VAC, that may not be sucking out the thing from the deeper pocket. Some blind area may be there. That is another possibility. We had such a situation actually. So it was near the vascular thing, and we put a VAC and we removed the dressing after 3 days. But actually that there was a little collection around the vascular pedicle. Initially we have given thorough lavage, but still there will be some particles. Some particles may be left. We don't know. And thorough clearance was being done, but still we had a bad issue.
Yeah.
So that also is
Yes.
another this one.
Yeah. Thanks, Joshit, for bringing out that. So putting a whack and forgetting about it may not be the right policy. You need to be watchful. I think Rajendra made a very important point about the 2 supramajor surgeries rather than multiple follow-ups and multiple procedures, cutting down the number of surgeries. So I remember my teacher always, Dr. Sabhabati, always used to say, the poor treatment is the costliest treatment. So you have to do the right things, no matter how costly they appear in the beginning. Thank you, Rajendra, for reminding us that. That brings us to Dr. Ravi Mahajan, who will speak to us about major amputations that has happened in the hand, and he more specifically is going to speak on segmental amputations. Dr. Ravi Mahajan, as you all have heard, he is the president of Indian Society for Surgery of the Hand, and he works in the holy city of Amritsar, and he is the chief of plastic surgery and hand and reconstructive microsurgery at Amandeep Hospital, which is called the Ganga of the North. So welcome, Dr. Ravi Mahajan.
Yeah, thank you, Pankaj. So thank you so much, and I again welcome all the attendees on behalf of the Indian Society of Surgery of Hand, and thank the Bombay as well as the Maharashtra Orthopedic Association for giving the Indian Society of Surgery of Hand this opportunity to be part of this momentum. So I will be, sharing with you some of our experience of the segmental amputations of the hand. So what I mean by segmental is most of the time the amputations which we see are usually, the transverse amputations. Whole of the hand may be amputated, whole of the limb may be amputated, or thumb or finger, or multiple fingers may be amputated. But then we have come across at certain times the amputation of a segment of the hand, and which will involve not one particular thumb or the finger, but a segment of the hand, as I will be showing you these cases. So we have a series of about five of these cases, and I will share you with those. And this is the case, first case we have, and this is a 23 years old male who had a machine injury with a wood cutting saw. And there was an amputation of a segment from the radial side of the wrist. As you can see, that this is a small segment, which is amputated while, he was pushing that wooden log into that saw. His hand, part of the hand got caught, and this segment, was taken off, and it involved distal part of the radius, radial 3 metacarpals, radial vessels, and the median nerve, and the FDS of index and the middle finger, those were also cut. So as you can see here, that this segment of the hand, so that is totally kind of cut off. Now, the thing is that if we are not able to put it back, the reconstructing this part with the help of flaps or bone grafts will never be able to give the same kind of a reconstruction which we will be able to have by putting back this and reimplanting it. So that is what we thought we'll do, rather than trying to reconstruct it in a different manner. And you can see here in the radiograph that the part of the radius, the carpal bones, and the part of the first three metacarpals, so that were also gone. And in addition, to the FDS tendons, there were, the FPL, APL, EPB, EPL extensors of index and the middle finger. They were also cut at 2 levels. Then ECRL and the ECRB tendons were also cut, and the slicing of the bone segments was there, as I have shown it here. So in this case, what we did was that we did the bony fixation by using the K wires. The radial artery and the 2 bony components were repaired, in order to vascularize this segment of the hand, which was amputated. We could repair the cephalic vein, and the superficial branch of the radial nerve, that was also repaired. But as far as the tendons were concerned, so they were badly damaged and they could not repair. And you know that this wood cutting saw is not exactly a sharp kind of an injury, because there is a lot of avulsion element also, and many times the tendons are damaged beyond repair in these cases. So by doing so, we were able to put back this segment, and structurally were able to completely reconstruct this part of the hand, which otherwise would have been very difficult to reconstruct with the other options. The only problem which we have in these cases when we are putting it back is that you see, because you are not able to do any kind of a shortening in the transverse direction, so it is very difficult to suture the skin back. So though we were able to suture the skin back on the ulnar side, as well as distally, as well as proximally, but here we had a small defect, which was skin grafted. So this is how we reconstructed it, and then he was put on the physiotherapy and was developing, improving his hand function. But then we had lost him to follow up because he was a migrant labor, and then he went on. Though we don't have the latest, what the function of this hand is concerned. So we had, another similar kind of a segmental amputation in this 50-year-old male, again with a wood cutting machine injury. And there was a total amputation of the right thumb through the CMC joint. But then it is not only about the thumb. Why I call it segmental is that in the amputated part, there was a segment of the second metacarpal also, just distal to the second carpometacarpal joint. As you can see here, that there is the second metacarpal also, which was there in the in this amputated part. And again, here, if we were not able to put this part back, only his thumb is not gone, but his index finger is also going to be affected. So that is why it was very important to put this segment of amputated part back, not only to have his thumb back, but also to have a functional the index finger as well. So again, in this case, we arthrodees the CMC joint, K-wire fixation of the second metacarpal was done, and flexor and extensor tendon they were repaired, and radial and the ulnar digital arteries of the thumb were repaired, cephalic vein was repaired, digital nerves were repaired. And again here, as I was explaining earlier, so we had a defect here which we had to skin graft. Whenever you have this kind of a segmental amputation, you may fall short of the skin, and you may have to do the skin grafting on one of the sides. And here you can see that we were able to restore his thumb as well as the index finger by reimplanting this segment of the tissue, which was amputated from the radial aspect of the hand. And then he has a good function, and since he was a manual labor, so he was able to do all the major work with the same hand, which was very badly injured. Now, coming to my third case, this is exactly not an industrial or a farm injury, but this was an assault injury. And we see a lot of assault injuries, and they also come from rural areas, because of these land issues. In Punjab, we see a lot of these kind of assault injuries amongst the farmers. And this was a 40-year-old male and who had a total amputation of the thumb. But in addition to the thumb, there was the amputated segment also had the thinner as well as the hypothinner area. You can see that part, in addition to the thumb, the part of the wrist, that was also taken off, and there were radial and the ulnar vessels were cut. The median, ulnar, and the superficial radial nerves were cut. FCR, FCU, FPL, long flexors of the fingers, EPL, APL, EPB at wrist level, and then at the mid palm level also. So 2-level injuries were there of these tendons. And as you can see here, that this is having a lot of bones of the carpal as well as the metacarpal region. So there was a devascularization of the distal part of the hand also. So now, if we were not reimplanting this, we were not only losing this part, but we were going to lose this part of the hand also, and he would have landed up in an amputation at the forearm level, because what was left was only a segment of the skin. So here what we did was the K-wire fixation of the bones were done, radial and ulnar vessels were both repaired. So as far as the radial vessel was concerned, so that was actually supplying this amputated part, and the ulnar artery was going to supply this distal part of the hand. So this is how the two vessels were useful. And then cephalic vein was repaired, and the repair of the median and ulnar nerves was done. All the flexor tendons we were able to repair at both the levels, and EPL, EPB, and the APL tendons were also repaired. And this is the final result we had. We were not only able to put back this whole of the amputated part, but were also able to save the distal part of the hand also. And he had a reasonable function of the hand as well. And as far as these segmental amputations are concerned, because they have 2-level injuries to the tendons, and many times these tendons may not be repairable, so the hand function may not be as good, but still it gives you a reasonable level of reconstruction as well as the reasonable level of the anatomical reconstruction. And as you can see that he is again a farmer, and he has got a good function of the hand, and if he is able to drive his motorcycle and do all his the farm work with the same hand, which would have otherwise landed him up in a amputation at the forearm level. And this is our fourth case, again with the wood cutting saw. So these were all, happening with the wood cutting saw. And here he had a segmental amputation involving the left thumb as well as the proximal metacarpal of the index finger also. So that is why it is segmental, that in addition to thumb, this part of the index finger was also cut. So in this case, we were not able to save the index finger. We had to amputate the index finger, but then we were able to put back the thumb and were able to give him a good functional hand, though there was a loss of the index finger. Again, in this case, we did the ulnar digital artery repair, cephalic vein, digital nerves, FPL tendon was avulsed, so that could not be repaired, but everything else could be repaired, and he had a good structural as well as reasonable function of this hand as well. And this is my last case in this series of segmental amputations. And this was a 50-year-old male patient, again with a wood cutting saw kind of a machine. And here you can see that the only thing which was left was just this 5-centimeter segment of the skin bridge, and this whole segment, that was taken off. So now the only way to reconstruct is to put it back. Otherwise, you can't put this part of the hand here because that will be almost useless, or you will have to do a amputation at this level. So we had to revascularize this part of the hand also, and at the same time reimplant this amputated segment as well. So in this case, as you can see that all the structures, they were cut. The only thing which was left was some about 5 centimeter of the broad skin. And this is the radiograph, showing this segment of the amputated part of the hand, and where all the tendons were cut actually at both the levels, and wrist flexors and the wrist extensors were also cut, and all the carpal bones and the proximal part of the second to fifth metacarpal, in addition to the thumb metacarpal, they were also there in this amputated segment, and there was no distal circulation, as I said. And again, debridement is the first thing you have to do, and then you have to do some bone shortening and bony fixation, and then of course the vessels have to be repaired. So in this case, the revascularization of the distal segment we did with the ulnar artery using a vein graft. So as you can see here, so here the ulnar artery repair was done using a vein graft, whereas the radial artery was repaired to vascularize this segment of the amputated part. So ulnar artery with the vein graft was revascularizing this part of the hand, and the radial artery was vascularizing this amputated segment. And then, of course, the median nerve, ulnar nerve, and all the tendons and the dorsal veins, they were repaired. And extensor tendon, of course, could not be repaired because there was a loss of the intermediate segment. And this is the result we were able to have. We were able to vascularize his distal hand, and as well as put back this amputated part also. And he had a reasonable function of the hand after. Actually, we could not have a very long follow-up with these patients, because many of these were workers working in these places, and initially, though they were supported by their employers, but then later on we lost them to follow up, and could not have a very long follow-up with these patients. But initially they were doing quite well, and had they persisted with the rehabilitation, probably we would have been able to assess their functional results much better. So to conclude, I would like to say that these segmental amputations with multiple level of involvement transversely, they must be considered for reimplantation, though the functional results may not be very good, but the reimplantation of amputated part is much better than any other form of reconstruction from aesthetic as well as the functional point of view. And this is just to show you this video of that wood cutting machine, when they are pushing this this log of when they are pushing this log of wood, that is when probably if they don't take any precautions, the hand is likely to get caught, and some part of the hand that may be cut off. Thank you so much.
Thank you so much, Dr. Mahajan. I think that was fantastic. This is the first time I saw a presentation of segmental amputations. That was fantastic. There are a few interesting questions from the audience. One, of course, is I would put it to collectively to all the microsurgeons on the group. Is there any particular precaution or a procedure before you put a VAC on a wound which has a microsurgical reconstruction done? Could the VAC actually potentially damage your microvascular repair?
Yeah, if the VAC dressing is covering the vessels, which you have anastomos or the recipient vessels, obviously it will damage, because it's quite a high suction which is applied to the VAC. So it should not be put any vessels. There are certain contraindications to use for use of a VAC. That means the exposed vessels, exposed bowels, or the open cavities of the body. So there the VAC should not be used. You have to have some intervening tissue. Maybe you put a skin graft and put a VAC over it, but not directly a VAC, because the sponge also gets, the special quality of sponge with the porosity it has, it gets stuck to the wound. So you can't allow the sponge to get to the vessels. But anyway, even for the vessels, even if you put a graft, you should not put a vac on it. So out of question.
Unrepaired vessels may not cause any problem, but even in an unrepaired vessels, you should put it only at 50 to 75 millimeters, not a 125, which we normally put for a vac. But a repaired vessel, definitely not. We have had an occasion where we have done a major revascularization and a lot of degloving was there. And that was quite some back, maybe 6 to 7 years back, initial vac period. And we had put a vac at 100 and we could see there was ischemic damage to the index and middle finger. And we had to actually amputate those 2 fingers. So vac in a post-replant, post-revascularization, I think you have to be very careful and maybe avoid it totally. There is a modification people have tried, which was there in one of our vac session webinars. There they put a ab gel or something as a barrier between the vascular repair and the tissue and the vac. Or you cover with some local muscle so that directly it doesn't come on the vessels.
Dr. Mahajan, you had a comment to make?
Yeah, I think there is no doubt that exposed vessels should not be, covered with a vac dressing. But another thing which is very important is that if you are not sure about your debridements, so never put a vac. Again, this is dangerous to put it on a wound where the inadequate debridement has been done, because vac is not a substitute for debridement. So that is also very, very important. And what I have seen is, you are not able to see the wound, when the vac is on. And if there is an inadequate debridement, then I have seen in one of the patients, where it went on to necrotizing fasciitis, where it was left like that for about 5 days. And then it went on to necrotizing fasciitis and, ultimately landed up with a amputation. So inadequately debrided wound, I would say, is also a contraindication for putting a vac. And if at all you are putting, then I think you must open it early. So maybe after about 48 hours only, and don't leave it for 5 days.
There was one more question about the handling of the amputated part. The question was, many times these accidents would happen far away from the medical setups. Is there anything that the public could be educated to do to the amputated part to improve the chances of survival later on?
Hari.
Yeah, so the only thing the public has to do is basically do nothing. Just put it in a plastic bag and not wash it, not try to clean it. Just put it in a plastic bag which is available. Now, in many places, plastic is banned. So you need to even cover it in a cloth. If it's a big part, we advise them to cover it in a clean towel or a clean t-shirt or anything. Put it in a bucket and then surround with ice. Now, ice you get in plastic bags. So the ice comes as water or which is frozen. So ice packs can be put all around it so that the ice doesn't come in direct contact, because ice is inside plastic. So that is the easiest thing people can do when they are in the periphery. They put it in a bucket, put the part surrounded by a towel, a clean towel or a clean t-shirt, and then put ice all around it and just carry the bucket. Or if they get all the shops around the highways have got this where they keep Pepsi, Coca-Cola, and that box they have. So they just empty one box, put the part into that box and surround it with ice, which is there used for the cold drinks. So that is the best way to transport in most of the situation. That is the easiest and simplest. Not do anything to the part. Don't wash, don't clean, because many times a lot of tissue is hanging and you try to wash and clean and then you try to cut off something. So all those should not be done. Similarly, on the proximal side, put a towel or put a t-shirt and just put a firm dressing. It should allow your little finger. So you should not strangulate it. No tourniquet is preferable. Mostly if they go to some doctor or some place, they try to put an artery forceps or something. If you want to ligate like what Dr. Joshit presented, distal most area, you can ligate it and keep, because most of the time we are going to shorten the limb. So ligating is safer than putting a instrument, because the instrument can come off on the way or in the transit. Yes. And always open the dressing under block, preferably, not in the casualty department and not in place, because the disasters happen when they reach the hospital. They have been bloodless or no blood loss throughout the way. The moment they come to the casualty or in your department, in your hospital, you open it without giving a block and patient is screaming and it starts bleeding at that time. So don't remove anything which is stuck or any instrumentation without giving a block.
Yeah, Rajendra, you had something to say?
About the public education, about the transporting the part. I'll tell you, I have seen many times that there are many articles which we publish and the news we publish. But unless and until the patients and relatives face the problem for themselves, they don't remember it. And my simple way is to publicize your number or a hospital number to such an extent that when such injury occurs, they will be able to call you. So many of these people and my old patients, I always give them my mobile number that if you find such patient, just give me a call. And I have been successful in getting calls for almost 90% of the replants. They call me personally or they call my hospital, and we can guide them actually what is to be done exactly. And that is my way of working and my thinking. But anyway, we have to write more and more articles. We have to publicize every replant what we do in our area, and we have to publicize in a big way. Then only the patients get educated properly.
Okay.
Our point is that in any hospital you are working, every member of your hospital should know how to transport amputated part, because invariably they will call your hospital number. And if your own hospital people will not be able to answer, that is the worst thing to happen. So you need to, right from the canteen person to the stretcher bearer to the security person, whoever is handling the telephone calls or whoever is in charge, everybody should know how to bring the amputated part. Common mistake is they call the hospital and the hospital people themselves will say, oh, it is 6 hours, don't bring. Or if the patient is bleeding, don't come. So if your own hospital people are not aware, so I think the best way to educate is educate all your people who are in your hospital.
In fact, many times if they call the on mobile of a person who's working with you. So for some reason they get mobile number of somebody and they call them. So your hospital staff has to be first educated very well, so that they can answer it well. What Hari says is a very, very valid point.
Dr. Jindal, yes, Dr. Mahajan, you had something to say?
Yeah, the most of the time what I have seen is that whenever they go to a doctor, local doctor, in village or in their town, so what they do is they will immerse the part in either ringer lactate or the normal saline, or many times 5% dextrose. And one of the time I got it immersed in formalin also. So I think the worst thing is actually done by unfortunately by the doctors, and fault probably lies with us that we have not been able to educate them so well. And so what I think Rajan and Hari are saying, that we really need to publicize as much as possible, at least amongst the medical fraternity, so that they at least send it in a proper preserved manner. And that really makes a difference.
Yeah, I think it comes from the obligation to do something, and not realizing that doing nothing is the best thing that they could do. Dr. Jindal, I had one question for you about debridement under tourniquet. So you have any comment whether you should use tourniquet for debridement or you should not use tourniquet for debridement?
You debride under tourniquet. Once you release the tourniquet and see anything is unhealthy or it is dead, you still do a subsequent part, but it's under tourniquet.
But you do not necessarily have to do debridement without tourniquet. You can do an effective debridement under tourniquet.
Yes. To add to whatever is that second part of it, the worst thing is people adding turmeric to the wounds. If nothing, they add at least turmeric there, and cleaning turmeric is a nightmare. It takes lot of unnecessary waste of time there. I don't know what's your experience, Rajan, if you notice that.
Yeah,
turmeric is something that we have noticed very regularly.
It's true. Many times we get turmeric in the wound. But Pankaj, talking about the tourniquet, what you said is it is better. It is not better. It is mandatory to do debridement under tourniquet for all the extremity wounds.
Yeah, it's not mandatory, but majority and generally speaking, it's under tourniquet. Yes, if it's bleeding, definitely yes. It's not bleeding, then of course we do inflate. Now there will be a situation where you don't inflate the tourniquet. The vascularity is in jeopardy. You don't know what's happening. So you put the tourniquet in, you don't inflate it, you debride, because anyway it's a devascularized part here. So you can continue your debridement The moment you see vascularity, you know, there you have to stop.
Thank you, gentlemen. Swapnil, Sandeep, do we have time for a case, or we close here?
Oh, we can discuss one more case, Pankaj. I'm pretty sure that this session is going fantastically, and it would not be fair if we do not, have the last case coming in.
So I just have one simple case. I'm calling it simple in the light of whatever we have seen till now. We have had such accomplished and highly skilled presenters. So I'm just going to present a very simple case. This I did many years ago, but I just thought it would be a good case to discuss. So that's me. Are you able to see my screen?
Yes.
I don't know why this is not working. Okay, that's me. I represent the Indian Society for Surgery of the Hand, and all those who are watching and those who are interested in hand surgery, I invite you to join ISSH. Just visit issh.org. We are a highly academic body. We are almost completing 50 years of existence, and we are committed to give back more to members than what we receive from members. Welcome to ISSH. So this was long ago when I was working in a public hospitals, and one fine day I was called upon to see this hand of another unit. This patient had his name is Shiv Naresh, right hand dominant roadside vendor. It was already 2 weeks since injury. He was nursing a pelvic fracture which was being treated conservatively, severe anemia. And of course, once the fixator was put, right, wrong, whichever fashion, the hand became less of a priority. When I saw him, he was extremely foul smelling. There was obvious infection, pouring pus. There was a composite loss. A segment of the hand was lost. It was not available. And if but for this fixator and wires holding it, then this hand would be completely dangling. So there was obvious instability because of a loss of the skeleton. And to see that this is how he actually presented in the first place. So a lot of right things could have been done on day one as per the principles that were discussed today. And this is what my teacher used to say, the poor treatment is a very costly treatment, because he did not receive the right treatment on day one. His agony gets prolonged, and then there's a prolonged hospitalization. From here, he was advised amputation actually, and the patient did not want amputation. So, and since we had good manpower to keep dressing this wound, the junior most house surgeons keeps dressing until the patient starts crying for help again, and kept dressing. I think this went on for 2 months. The infection never subsided. A few wires walked out, a few wires stood out, and this was the ultimate condition of the hand. It was at 2 months, there was still infection. It was very stiff. The fingers were still floating despite this fixator. There was nothing to hold them to the wrist. There was a good amount of granulation tissue, as would happen in presence of infection and with time. Good part was the palmar skin had healed well, and he had sensation in the fingers. These were the only two positives. There was complete loss of extensors. However, the flexors were still having a flicker of movement. And then we decided to put a soft tissue cover on this. The moment the fixator was removed, the hand was completely dangling. The fingers were very stiff. So the priority, of course, was to get a soft tissue cover, get to a skeletal fixation where we can start mobilizing the fingers. So that was the palmar skin, which had healed by now. And we took a large abdominal flap, thanks to my exposure at Ganga Hospital, a pedicle flap based on the, it was a mix of a hypogastric and a groin flap. A large flap was put. He continued to have some amount of discharging sinus because the bone did not heal. And then we started working on his fingers. Now, one of the important thing that the skin cover does is it allows you to start thinking about other elements of the injury. Once this was there, then I could think of getting that sinus healed, removing the dead bone, trying to get a skeletal fixation. So the gateway to reconstruction in a compound, in a composite loss in the hand, the gateway to reconstruction is through a full thickness cover. If you don't have a full thickness cover, all your options for reconstructions are virtually closed. With this flap cover, we started mobilizing his flexors, and he was able to get his thumb to the finger, and you know, that dramatically improves the outcome of this injury, and a lot of function is immediately restored. Next option, of course, was to get the wrist to stabilize. So we debrided the dead bone, and we again put a very small fixator. The purpose of fixator was also in such a way that, you know, the position of the fixator would also be in such a way that it would be a low profile fixator, would not come in the way of mobilization. And what was done under this flap was we put a large chunk of iliac crest bone graft, hoping that it would unite at both ends. It did not, but the fibrosis around the graft and the debridement that preceded this grafting actually made the sinus heal and gave him a very respectable hand. The plan after this was, of course, an extensor tendon reconstruction under the flap, but the patient never came for follow-up. I had a small video after this, but I cannot play it for whatever reasons. That there was some compatibility issues. So this is where we have the implant has come off, all through the healing process, which was very long. This bone graft took almost 3 to 4 months to heal. The fixator held on, and he continued to use his hand. That is how the skeleton looks there. And he's still waiting for a skin graft, has never come back for many, many years. So from here to here, it was a long journey, and he continues to have a good, useful hand. That is an important thing. Amputation, as advised to him on the first impression of this hand, is not an option. Remember, intact palmar skin is a big positive, no matter what is the extent of the injury. If you achieve a good soft tissue cover, which is almost always possible with microvascular reconstructions, it opens a big doorway to future reconstruction. You can do a whole lot of things under that skin. And remember, as my teacher has always said, for someone who has lost everything or is about to lose everything, a little means a lot. Restore whatever you can. Amputation is not an option in the hand. So that's a small and simple message I would want to give. I would want comments from any of the senior faculty, which would act as a closing comment also for this session. Thank you very much.
I think, Pankaj, it's a very nice reconstruction, excellent reconstruction. And as you said also, in neglected wound, you need to remember that bacteria, the only thing which is not resistant to the bacteria or bacteria not resistant is the scalpel. So use your scalpel and debride it well. And that's what you did. So you debrided it so well. When it is already infected, the debridement extent has to be more aggressive than the acute situation. So I think that is one. And second is very good, like a philosophical message to all, is that when you face an injury like this, or even when parts are brought late or patient is referred late, the first thing the patient asks is whether if you had come early to you, would it have been better? So that immediate tendency is to say, oh, you should have sent us early, or patient should have been referred early, or if you had, so better not to blame anybody who was treated. So the way I tell them is that they have done to their expertise. So I tell them, give an example. If you have some problem at home, you have an expert, he does it well. And if you don't have an expert, then they're to their best ability, they have done. They have saved the limb, and now they have sent it to us. We are the experts, so we will treat it and save your hand, make it functional. I think that's another very important thing to remember, that if somebody refers you a case that he's become so desperate that he cannot handle it anymore, and that's why they usually refer to you. So otherwise, an excellent reconstruction.
Dr. Mahajan, Dr. Karthikeyan, you have a comment?
I love that point about the gateway to the reconstruction, the soft tissue. One of my professors, Dr. Krishnamurthy, used to say, when the patient would ask, "Doctor, can this hand become totally functional?" He'll say, it is like winning a lottery ticket. Okay. And buying the lottery ticket is giving a flap cover. So after doing this, you may not get back complete function, but there is a chance for getting back function, and you have proved it very nicely in your reconstruction. Good.
Dr. Mahajan, would you like to summarize the session and give a message to the audience?
Yeah, I think first of all, I must congratulate you on this very good case which you have shown, because I think even when the patient comes late to you, you still have something to offer, if you follow the same principles of radical debridement, soft tissue coverage, and, then follow with the secondary procedures. So I think it all, basically sums up that we must try to get these patients fresh, as they say, catch them young. So you have to catch them fresh, so I think it is a very important message for us to convey to the whole medical fraternity as well as to the patients that they should report to a, hand surgery center with the fresh injuries, because whatever, said and done, when patients come late to you, then you may not be able to give as good functional results, as it may be possible if they come to you right in the beginning. So I think as a society, both for the Indian Society of Surgery of Hand as well as for the Orthopedic Society, is very important to, get across this message that these patients have to be dealt with, well, right in the beginning, because like Dr. Pankaj showed, patient came to him at 10 p.m. at night, and he could, reconstruct it. He could put those parts back, those segment of tendon, segment of nerve, as well as the bone, because he did it in the middle of the night. Had he, probably waited till, the next morning, it would not have been possible to reconstruct those. So, and that is only possible, if the patient will go to a hand surgery center where there are, specialist hand surgeons available. So that it is very important to send across that message to all of our colleagues as well as to the general public, so that, we get them fresh, rather than getting them late. You can always give very good results. And as far as the cardinal principles are concerned, I think all the, speakers have elucidated those very well. That, the Hari has given those, 10 commandments, and Joshid has also, said those, and, all the people, have highlighted those points. And I think as far as our own fraternity is concerned, I think it is very important for them to follow these principles, starting with the radical debridement. And as it was discussed, it's not a cancer-like debridement, because in cancer you remove it in a single piece. Here it is, I think, would like to use the word radical. Whatever, is doubtful, that has to go off. And then next thing is to early soft tissue coverage, and I think very well said that that is the gateway to your reconstruction, whatever reconstruction you have to do later on. So that is going to depend upon what kind of a soft tissue cover you have given. If you have given a very good soft tissue cover, you will be able to do all the reconstruction very well later on. And as far as possible, we must try to reduce the number of procedures to reduce the cost also. So whatever can be done primarily, we should do that. As you asked the question about the extensor tendons, I think that is true about most of the things, wherever possible. And that will be possible only if the patient is coming fresh to us. So because if patient is coming in an infected state, then of course it has to be staged. But if patient is coming fresh to us, we will be able to do the primary tendon repair, nerve grafting, or whatever, there is a possibility of doing that. So I think getting these patients fresh to a hand surgery center is very, very important. And that is one very important thing, which we have to probably propagate, to everyone in the medical fraternity as well as outside, so that, we can reduce the morbidity as a result of these hand injuries. And I think these centers at Stanley Medical College and Ganga Hospital and, Rajendra Nete and so many of you have done a lot for getting these patients. I think what Dr. Venkataramani did at that time, just follow that red line. So idea was that there is no delay. So because delay is going to be detrimental. I think that is what we have to carry forward, which the path was probably shown to us by Dr. Venkataramani in the form of that red line. So get those patients, well in time. So I think that is a very, very important message which I would like to convey. And thank you so much again, all the office bearers of the Maharashtra Orthopedic Association, Bombay Orthopedic Association, and Pankaj, of course, coordinating very well with them and, getting off this such a beautiful webinar and, and very nice presentations from all the speakers. Thank you so much.
Thank you, sir. Dr. Jindal, you have any closing comments before we close the academic session?
Dr. Jindal has left. He had some urgent work.
So just before we close the academic part of the webinar, Dr. Mahajan mentioned about the red line. So many of the orthopedic audience who may not be aware of what this is, this was Professor Venkataramani's brainchild in Stanley Medical College, where in order to direct all the hand injury patients to their rightful place, which was the hand surgery department or the plastic surgery department, where they would be seen by the plastic surgery residents directly, rather than they hover around in the hospital and sometimes get lost in the sea of patients in Stanley Hospital. From entry of the hospital till the plastic surgery, where the plastic surgery resident was available to see the patient, he had put a red tape on the floor, on the wall, that if you have a hand injury, follow this red line. So yes, Karthikeyan, I was trying to steal your opportunity.
Yeah, and one more thing was there was a prominent board put up in the casualty which says, when patients come with a dressing on the hand, the dressing should not be removed in the casualty and patient should immediately be sent to follow the red line to reach the hand surgery department. That those 2 points, the red line and no dressings in the casualty.
So that's the story of the red line. Thank you very much. Thank
Pankaj,
you.
can I make Pankaj, can I make one more point? I think one thing, which the Ganga Hospital is doing right now, I think that is the future for hand surgery services in the country. Wherever we are developing, particularly those dealing with the trauma. Having a senior person, looking after the patient right in the beginning is very important. And this again, was being followed at Stanley. When I visited Stanley, probably sometimes in 94 or 95, I saw that, the one consultant will be on duty, even, I think after Dr. Balakrishnan, whosoever was the second consultant, he also used to do the duties. So that was being followed at Stanley, even at that time, that the senior consultant will be there in person, to see all those patients and take a decision. Because I think decision making is the one which is very, very important. The implementation, probably can be done maybe sometimes at junior level also, depending upon whatever it is. So that is the future actually. If we have to, develop hand injury services in different parts of the country, we have to have that much of strength, that you have at least 6 or 7 people available to you, so that every day there is a one person there, to look after these patients. That is how we can probably reduce the morbidity as a result of the hand injuries, and the right decisions are taken and all these working hands are saved. So I think that is a fantastic thing which Ganga is doing right now. I think that should show us all the way to develop hand injury services in different parts of the country.
Thank you very much, sir. And I thank all the speakers, Dr. Ravi Mahajan, Dr. Karthikeyan, Dr. Jindal, Dr. Hari, Rajendra, and Joshit. Thank you very much. And Swapnil and Sandeep, thank you very much for giving us this opportunity to ISSH to talk to a much larger audience about what we feel about hand injuries and especially the industrial hand injuries. Over to you. Thank you very much.
Thank you very much, Dr. Pankaj, Ahire. And on behalf of the Maharashtra Orthopedic Association and the Bombay Orthopedic Society, I express my deepest gratitude to the Indian Society of Hand Surgery for putting up such a wonderful webinar where the entire gamut, the entire spectrum of industrial hand injuries was shown in such a beautiful and elucidative manner. I would be extremely grateful to all of you all, and I'm looking forward for a large participation and a large contingent from the Indian Society for Hand Surgery for IOACON 2021 in Mumbai. Thank you very much.